Sports Medicine Clinic, Head Physical Medicine and Rehabilitation at PGI Chandigarh. He is past President, Indian Orthopaedic Association for 2018. He is Chairperson, Research AO Trauma Asia Pacific for 2017 to 2020. He is Chairperson AO Trauma India 2014 to 2016. He is Founder President, Indian Biologic Orthopedic Society since 2014. Well, Sir has trained more than 200 PGs in orthopedics and has 370 plus major publications. He has delivered 10 orations and has more than 300 presentations at various conferences, national and international, and has been awarded Best Paper Prize 6 times. Sir is Honorary Consultant to BCCI in India, Sports Authority of India, Indian Hockey Federation, and Gymnastic Federation of India. So over to you, sir, and thank you for being with us today.
Hello, good evening, everybody. I am Mandeep Dhillon from PGI Chandigarh, and I am the director for the program on the foot and ankle trauma, which we are hosting along with the OTA, the Orthopaedic Trauma Association from the USA. And this is a 3-hour module, and I'll be sort of starting it right away. We won't waste your time. I'd like to welcome the OTA faculty. We've got 2 big names. We've got Dr. Tim White from Edinburgh. He is the Director for Trauma in the Royal Infirmary of Edinburgh in Scotland. And he's also a senior lecturer in the University of Edinburgh, along with doing a lot of work as the Director of Scottish Orthopaedic Research into Trauma. Across the pond, as the British would say, we have Dr. Kenneth Egol from New York, United States. He's the Professor and Vice Chairman, Department of Orthopedic Surgery in the NYU Langone Orthopedic Hospital. Thank you, both of you, for joining us. I know it's an odd time for all of you, but I'm sure we'll learn a lot from what you have to offer. From India, we have 4 guys who are long-standing culprits in foot and ankle, especially foot and ankle trauma. Balwinder Rana is a big name from Delhi. He is the Additional Director of Orthopedics with a specialization in foot and ankle surgery in Max Hospitals in Gurgaon and Delhi. And on the right, we have Siddharth Sharma, Associate Professor, who works in my department and is a rising star in foot and ankle surgery. He's actually doing his PhD on fractures of the talus, and he is doing a lot of work on this. From south, I won't say south, in the middle of India, we have Pradeep Manut, who is a very famous guy in Mumbai, who works in the Breach Candy Hospital and the HN Reliance Hospital in Mumbai. And he's one of the leading lights in the middle of India where foot and ankle surgery is concerned. Dr. Sandeep Patel, again from my institute, is an assistant professor in orthopedics, and he has a specific interest mostly, and he's done a huge amount of work on ankle, the fresh fractures, the old fractures, and he'll be sharing his views with us today. So if you look at the agenda, it's fairly simple. We've got it into 3 one-hour slots, and we've tried to have discussion on a case at the end of each slot, and it all depends upon how it goes. We'll see whether we can get in 1 case or we can get 2 cases. It depends. So we are going to start with ankle fractures, go on to talus injuries, and then go on to calcaneus fractures. And we'll end with some closing remarks, and we would be liking you to put in your questions in the chat groups, which I will be monitoring and I will be addressing to the faculty so that we can answer it as we go along. So thank you for listening in here. And now I'm going to stop sharing my screen, and we'll request Ken Egol to go on with his first talk on going prone.
All right, can you see that?
Yes, we can.
Okay, great. So thanks for inviting me for this very special event. I'm going to talk in the next 10 minutes about my I'd say over the last 5 to 7 years, change in practice of basically trying to fix every single posterior malleolus that I can, regardless of size. So I'm going to go into my rationale as I do that. These are my disclosures, nothing related to this. So I'm going to go over the indications and treatment principles for fixing the posterior mal. I'll talk about some common and uncommon pitfalls. I'll describe the approach, and then at the end, we'll have a little video demonstration. So, this is the problem that we see, the unstable ankle mortise. This is a trimalleolar ankle fracture with a dislocation out the back, large posterior malleolar fragment. And certainly we can all agree that this is a fracture that requires and is best treated with operative fixation. And whether or not you would go and fix this posterior malleolus is certainly debatable, but it certainly meets criteria based on size and instability. Now, recently there's been a more of a focus on the posterior malleolus, and we've known for years that size and articular involvement of the fragment has been an indication for repair of this injury, but it's also been described in various morphologies. And these are the three main morphologies. There's the posterolateral, which is the most common, the transverse, which goes out and exits all the way medial. That can be one or two separate fragments. And of course, the third is the shell, which is associated with posterior instability as well. So these are some of the proposed current indications. Absolute indications include, persistent posterior subluxation of the talus. Others have proposed joint surface involvement of anywhere from 25 to 30%, or any significant articular step-off, that being more than 2 millimeters. Now, I'm not so concerned about this portion of the articular surface and any incongruity. To me, the posterior mal, smaller fragments and lesser areas of articular surface involvement are really important for their contribution to syndesmotic instability. And, as we know, the posterior inferior tibiofibular ligament attaches to that posterior mal and forms the strongest connection between the tibia and fibula, and is the most stout of all four of the separate connections that make up the syndesmosis. So it would, ring true that by repairing the bony avulsion of the syndesmosis, you would thereby potentially obviate the need for transsyndesmotic fixation, whether or not you like to use screws or a suture fixation. Either way, you would not need to basically go across this joint. Now, to get there, there's two ways to get to the posterior mal, and I know someone's talking about the talus later when we talk about posteromedial, but in general, you can get to all of the posterior malleolar fractures through the posterolateral approach, which is between the fibula and the perineals, and then deep to that, you take the FHL off of the fibula, and you're right on top of the posterior malleolus and on the fibula as well. As far as the posteromedial approach, that's working around the neurovascular bundle, and I'm not going to really touch on that at all. And this is what it looks like. You're sitting prone. The incision is between the Achilles and the fibula. Once you make the skin incision, you get down to the superficial fascia. You open up the superficial fascia. You're in the deep posterior compartment, opening that up and working between the interval of the FHL and the perineal muscle belly. And this is what you can get to. You can get to the direct posterior surface of the fibula. And some people like to, swing the perineals medial and put the plate on laterally and work through two separate intervals. I prefer to put my plate directly posterior, right on the triangular portion of the fibula, where I think I get the best buttress effect. Then you can see that the posterior mal is nicely visualized. I always start with the fibula, and by reducing the fibula, I get the length, and the posterior malleolus on the tibia generally reduces very, very easily. So here's a video which I will narrate, again, demonstrating the posterolateral approach. This is the positioning that I like, prone on a bump, making sure that ankle is above the other side for imaging. On lateral here, I'm marking out the Achilles and the lateral malleolus, and my incision goes midway between. Again, the sural nerve is going to cross the field right in the inferior portion I tend to do this with the limb exsanguinated, but certainly tourniquet is not an absolute necessity. Incision is made through the skin. In the area of the nerve, I always dissect with a scissor to identify the sural nerve and the accompanying veins. And there we see it. I trace it up, and I actually mobilize the sural nerve, and I bring it laterally. I bring it laterally because if you bring it medial, I bring it laterally, because if you bring it medial, it's going to cross distally and be right in your field, and you risk damaging it. Again, going through the fascia. I seem to have stalled. Oh, no, I don't know what happened. Oh, I'll move that. Get you back up. I've gone between the FHL and the perineals, and I'm coming right down on the periosteum here of the fibula. I'm not sure why the video is not playing. It worked when I tried it before.
Anyway, we can go on. Don't worry. You can explain it to us verbally.
Okay, maybe if I manually move things along here. I'm going to manually move it along, but
To hit the play button on the left side of the screen. Yeah, this one. The left bottom of the screen. Hit the play button. Yeah.
Yeah, I know. Except I got the wheel of death circling here on my screen. It's not, my computer's not letting me do anything. I'm not sure what's going on. Basically, what you want to do is you want to take the FHL off the fibula. It's a reasonable length. I don't like to work in a small area. I like to be working with the muscle completely mobilized, because I found that if you create damage to the muscle posteriorly, the patients end up with some clawed toes. So you want to make sure that while you're retracting, you're not creating any damage and ripping the muscle apart or creating any kind of vascular insult to it. Well, my video is not letting me play. I apologize. I retract with small fragment retractors, and I'm not sure what happened there, but I hope my other videos are going to work. I'm going to stop sharing.
Can you escape the slideshow and then
Yeah, you can
go back to the same slide and
probably come back again.
come back? Yeah.
Okay.
Otherwise, we have a similar video in the next talk also.
Let me go.
Now you can see if you can play the video.
Yeah, I'm trying.
Yeah. Okay, go to this half of, pull it up right till the middle. Yeah.
Yeah, I'm trying. I also have the video on my computer separately. Maybe it'll play better if I just play the video.
Maybe you could try that.
I don't know. I've given this talk before and it's worked all the time, so I'm not sure what's happening. I can't.
No problem. You just hit escape or stop sharing the screen, and we can have a common discussion after Sandeep Patel. He's got a similar video which is going to be showing, if I'm not wrong. So, have you stopped sharing your screen, Ken?
Yes, I stopped sharing.
Okay, we'll just have the talk. You can give us the important points right at the end of the next one. Sandeep, would you be kind enough to talk about your posterior malleus, and then we'll have a combined discussion.
Okay. My talk is unstable posterior malleolus fracture. Unfortunately, I had a video again because the prone, I thought you will be doing it. I will be touching about the other aspects with some clinical cases in between. Yeah. So the outline of my talk is the relevant anatomy to understand the ring injury concept, the radiography, which is important, the classification, approaches, the posterolateral, posteromedial, and when combined, and most importantly, the sequence of fixation to determine the stability which is caused by a posterior malleolus fracture. The whole thing is important just because in anatomy we can see the PITFL is inserted onto the posterior malleolus. Apart from that, the posterior mal also contributes to the articular surface, the posterior rim. The next important is, you can see here the PITFL in one of our clinical cases of ours. It contributes 42% of the strength. Apart from that, the posterior malleolus also gives stability towards the posterior translation of talus when the fragment is much bigger. But most importantly, as it was emphasized in the previous talk, it is the syndesmosis, the syndesmotic stability, which is most important when we're talking about the posterior mal. Gardner et al. In their classical paper said that the stiffness was restored to 70% when we fixed the posterior malleolus in comparison to 40% after a syndesmotic screw. We need to understand the ring concept. In the coronal plane, there is a greater ring, which includes the syndesmosis, the deltoid ligament, and the lateral ligaments. And in the lesser ring, that is the syndesmosis, in the axial cut, the break can be a single break, a double break, triple break, or a quadruple break. The next is based on the size. It also contributes to an articular surface. So which is that reasonable percentage? In the last 30-40 years, there was a discussion less than 30%, less than 25%. But this particular study is important. You need to understand, in this biomechanical study, they had two groups, created a small posterior malleolus fracture, and in one group, they fixed everything, the fibula, medial malleolus, syndesmotic screw, and posterior malleolus. And in the other group, they did everything except for the posterior malleolus. Remember, it was a 25%, the smaller fragment. And they noted that it improved pressure distribution. To understand this, I'll present to you a case. It's a 40 years female, a polytrauma, multiple fractures, a spinal fracture, and acetabular fracture, also had an ankle fracture. But unfortunately, this patient presented to me 3 months in my OPD. And this is the X-ray which I had. Whenever there's an isolated medial malleolus, always think about there something has been missed. So you can clearly see there was a posterior mal which was missed in this case. Got a CT scan done. Clearly, this is less than 25%. The articular congruity seems very good. But here you see, this will help you in understanding the biomechanics. The posterior malleolus has moved medially, and along with it, the fibula has rotated posterolaterally, resulting in the shift of the talus anteromedially. So the point of pressure is going to change. And you can see the diastasis, which is clearly seen. So this is exactly what should not have happened. However, the patient had a good a range of movement, because of which she didn't want a surgery even after thinking. But these are the patients who in the longer run, because it is not a true congruous joint, even a little bit displacement is going to make it so incongruent that there is going to be arthritis eventually. So why was that missed? Because a true lateral radiograph can never pick a fracture because of the obliquity and the fracture angle. And then Abraham had said an external rotation lateral view. Again, it is not always the standard, because the fracture line can always vary based on the fracture, because of which CD scan is always better. And Haraguchi have also classified, which was already been described in the previous talk, into 3 types of fractures. And the second type is a medial extension type, which again has got 2 types, whether it involves the whole of the medial malleolus or just a posterior shell. Posterior mal is seen in pronation external rotation 4 type injury, where posterior mal is the last structure to be injured. In a supination external rotation 3 and 4 injury, as in this case, you can see a Weber B fibula, or in a pronation abduction injury. An isolated posterior mal, always think about it. In this case, you can see there's also a chaput involved. So we need to think and analyze carefully. So should we fix posterior mal? Does it improve outcome? Yes, it does improve outcome. Now, what should be the fixation? The AP screws versus the buttress screws? This biomechanical studies has clearly stated less displacement with the buttress plate, and clinical study where the SMFA scores were better for a posterolateral buttress plating, and another finite element analysis clearly stating the buttress plate to be superior over the posterior to anterior screw, which was in fact superior to the anterior to posterior screw. The surgical approach, the posterolateral approach, a very, very safe approach, which has, except for the sural nerve, which we need to be careful, but some fractures do need a posteromedial approach. You can see two contrasting cases. This is a Haraguchi type 1, which can be addressed with a posterolateral, but when we have a medial extension type, it may require an additional posteromedial approach. In a Weber's paper, where they have clearly demonstrated, this was a posteromedial and a posterolateral with the impaction of the posteromedial. Clearly, if you want to address the impaction, we would need a posteromedial approach along with it. So let's go to some cases. This is a 46-year female, road traffic accident, supination, external rotation injury, a Weber B fracture. We can see a posterior malleolus. We can see a deltoid ligament injury, Haraguchi type 1 posterior mal fracture. These are the intraoperative pictures. And as it was clearly stated, the entire thing has been done through the medially to the posterior buttress plate of the fibula, and the posterior buttressing of the posterior mal has been done. These are the intraoperative pics. This is the postoperative 6 months. This is another case, 26-year female, road traffic accident. Here you can see a type 2 Haraguchi. So here the medial malleus incision is slightly more posterior. This is a modified posteromedial approach, which needed to be buttressed first. And then we have gone through the posterolateral to fix the fibula and the posterior malleolus. So the surgeon should choose the most adequate approach based on the fracture pattern and their own experience. The sequence of fixation, for a generalized purpose, it's the posterior malleolus followed by fibula, followed by medial malleolus, plus minus the syndesmosis. Why the posterior malleolus? Here you can see the first posterior malleolus has been fixed. If I had fixed the fibula first, I could not see the reduction of the posterior malleolus. So for all beginners, it's always advisable to do a posterior mal first. However, in some cases, fibula first will help a lot, such as in this case, because the posterior malleolus is attached to the distal fragment of the fibula, and when we have such severe displacement, fixing the fibula will bring the posterior mal back into its place, and then the posterior malleolar plate was applied. Then the medial malleolus was fixed. Here, even after that, there was instability, because of which we needed to add an additional syndesmotic screw. You can see in this case, here the syndesmotic screw is not put, and you can see how unstable the syndesmosis is. Once we have put the syndesmotic screw, it is stable. So there are certain cases where even after posterior mal fixation, we may need a syndesmotic screw. That's exactly why a sequential stress examination is important. Here you can see the posterior malleus and the fibula is fixed, and now you can see when we do an external rotation stress test, there will be opening and movement of the syndesmosis. And when a syndesmotic screw was applied, that has been addressed. So a sequential stress testing is important. Another case, here a deltoid ligament supination external rotation injury stage 4, a small posterior malleolus. We followed the sequential stress testing in this case, and after fixing the posterior malleolus and the fibula, we can see the posterior mal and fibula is fixed. So this is before the stress test. This is after the stress test. It's not opening. So this case does not require an additional syndesmotic screw. So, and one more important thing is when we have this posteromedial fragment Haraguchi 2B, there is a school of thought we should fix this one first. Otherwise, if we fix the posterior malleus first, we may not be able to anatomically reduce the medial fragment. So this is one of our cases where that was followed, and we fixed this fragment first, followed by the posterior malleolus. So the answer is it does improve the outcome, and we should fix the posterior malleolus. More importantly, because of what is attached to it. Summary, CT scan is essential in all cases. It understands the fracture pattern and the morphology. There is no size requirement in dictating fixation. Remember, it is an important stabilizer of the syndesmosis. Fixation from posterior to anterior is the optimal. Posterolateral approach is the key. Choose posteromedial when required. Intraoperative stress views is very important. Plan the sequence of fixation with stress views. Thank you.
Thank you, Sandeep. I think we'll take questions after this. But may I request Dr. Egol has got his video going. She can show it to us for 2 minutes and then we'll take a couple of questions on this. Dr. Egol, you can share your screen.
Can you guys see that?
You can, but you can't see the video yet.
You don't? You see that? No?
No, we can't see the video playing.
You don't see the video? It's playing on my screen.
We're seeing Finder at the moment, Ken.
Yeah, we can see the Finder.
We're seeing Finder.
All right. Oh, this is not going to. I don't see this working.
No problem. We'll go along and see how it goes, and we'll take a call on this. Now, may I request Tim White to speak on fibular nailing, please? Tim, are you sharing your screen?
There we go. Can you hear me okay? And can you see that screen okay?
Yes, ready to go.
Okay, lovely. Well, listen, good afternoon. Thank you very much indeed for inviting me to speak at this meeting. It's been a fantastic couple of talks so far. I'm going to take a slightly different view on things and speak to you, if you don't mind, about the fibular nail. Now, in terms of disclosure, I should say at the beginning that I didn't invent the fibular nail. I don't receive royalties or any other financial inducements, but I am an enthusiast, and I do believe that it has a very important role to play in the range of treatments of ankle fractures. So let's start off with a clinical problem. Here's a typical sort of trimalleolar fracture in osteoporotic bone in a 68-year-old diabetic patient. And the range of treatments that might be offered for this patient would include close contact plastering, as per the AIM trial published last year in the Lancet, New England Journal, open reduction internal fixation in a standard AO manner with plates and screws, maybe an external fixator and a staged treatment, or a retrograde hindfoot nail. But I would propose to you that a better option than all of these is the fibular nail, particularly where soft tissues are compromised. So the rationale for considering a nail for the fibula is as follows. Firstly, and most importantly, to avoid early soft tissue complications, particularly in those patients who have vulnerable soft tissues, the elderly, diabetic, those with neuropathia, or those with traumatized soft tissues, for example, in the face of a pilon fracture. Secondly, to avoid late complications, and that's the prominence of metalwork that requires a return to theatre for removal at a later date. And finally, to improve mechanical stability on the grounds that an intramedullary device is more stable than a surface plate. So let's look at the surgical technique and see if I have any more luck with the video here. So the patient is under a general or spinal anesthesia. They're placed supine on the operating table. There's no tourniquet required. The incision is simply this 1 centimeter incision that's placed just distal to the tip of the fibula. And then a standard 1.6K wire is our guide wire, and it's placed up on the tip of the fibula. So these are the shots in AP in lateral view. There's then a 6mm cannulated drill and a T-handle, which prepare the distal and proximal fibula respectively. And then once the canal is prepared, this nail is then inserted through that incision and gently impacted up into place in the fibular canal. Now on II, that's the 6mm drill, then that's the T-handle that prepares the diaphysis, and then the nail into place. So the nail is now inside the fibula, but we don't yet have a locked construct. And so the next stage is to place firstly a distal locking screw and then a proximal locking screw, as for any nail. So the distal locking screw is placed from anterior to posterior, again through a stab incision. with the drill progress and the positioning of the screw being monitored on fluoroscopy. So once this screw is in place, the distal fibula is attached to the nail, which is attached to the jig, and fine adjustments can be made to the ankle mortise. And then once the reduction is complete, the whole construct is locked off by placing a proximal locking screw. Now, because of the size of the fibulas, proximal locking screw actually sits quite distally in the position that you might call a syndesmosis screw. But it's not to fix a syndesmosis screw or to fix an injured syndesmosis in the majority of cases. It's simply the proximal locking of this nail. So it passes from lateral to medial, first with a drill and then with a screw, and that prevents lateralization, rotation, and shortening of the malleolus. Once that construct is completed, the jig's removed and the wounds are closed with either steri-strips or sutures, depending on the surgeon's preference. And that's the procedure complete. The patient goes into a moon boot orthosis and is allowed to be fully weight-bearing from day one. Is there any evidence for this particular device? I'm going to show you 5 papers. For each one, there's a little QR code down in the bottom right-hand corner of the screen, which will take you to the relevant PubMed page if you want to pursue this further. But very briefly, we first published about a decade ago now our experience with the first 105 nails and the development of the principal technique for fibular nailing. We've performed 2 randomized controlled trials. The first, published in the BJJ, was in patients over the age of 65 and showed that the fibular nail had fewer complications, significantly fewer infections, equivalent functional outcome, and reduced cost compared with plates and screws once the cost of treating complications was taken into account. The second RCT, about to be published in the Journal of Orthopaedic Trauma next month, is the same trial of plates versus nails, but in patients younger than the age of 65. And that's shown the same thing, the fewer infections and equivalent outcomes. In collaboration with the group in Vancouver, we've also published the use of this device, particularly in diabetic patients. And finally, in our experience of treating type C tibial pilon fractures, we have also tended to use this nail to minimize the number of incisions placed around the ankle. So let's move on to a couple of technical tips. First is, when you first start using this device, you might find it easiest to open up the fracture and reduce it under direct vision. But once you've developed some familiarity with it, like a tibial or a femoral nail, one of the beauties is that you can undertake indirect reduction of a fracture. So, as for all nails, start point is key. Once identified, that start point allows you to introduce a 6mm drill, and then with a little bit of jiggery pokery, that can be placed into the perfect position in the distal fragment. And then the proximal canal is prepared with the T-handle, and then the introduction of the nail completes the reduction of the fracture. So that's indirect reduction. Let's look at a couple of cases. The first one is that same one that we looked at right at the beginning of this presentation, the elderly diabetic patient with swelling, bruising, and fracture blisters. There's the setup, as you saw in the video. This was a trimalleolar fracture, and my preference when we're doing these percutaneous techniques is to do these from anterior to posterior with direct manipulation of that fracture through a percutaneous approach. And then that is followed by the same sequence of events as you saw for the fibular nail. So a guide wire, followed by the over drill, followed by the nail itself. And all this is accomplished through these small incisions that respect the soft tissues. And there's that same patient at 2 years. The second one is the use of this device in open fractures when the soft tissues are more compromised. This is an elderly patient who's had a sort of standard transverse split on the medial side of the ankle, allowing complete subluxation of the dislocation of the talus. And again, using a fibular nail, this fracture can be, this ankle mortise can be reduced anatomically and allowed to heal, and with minimal additional soft tissue trauma to that envelope around the skin, around the ankle. Third case is really to reflect the fact that suprasyndesmotic fractures and fractures in more obese patients, where dissection is often quite extensive, can also be carried out with the fibular nail using indirect reduction techniques. So this syndesmosis has been reduced and held and then fixed with really, again, very little in the way of soft tissue dissection in this patient. Is there a dark side? Yes, it's not a panacea. The device has to be used correctly and with a degree of caution. And we recently reviewed 342 patients that we treated with a fibular nail. We had 94% healed without complications. There were some cases in which the device pulled out of osteoporotic bone, and this is a typical case. You can see slightly osteopenic bone, and the device is just pulled back. And we now recommend the use of 2 proximal locking screws in this situation. So far, we have had no further failures. The second source of problems is inadequate reduction or inadequate nail placement. And as an example, this fracture on the AP projection looks to have been reduced and fixed adequately. But if you look more carefully at the lateral projection, you can see that in fact the distal fragment has been missed. And without that being stabilized, of course, there is no stability to the ankle, which then displaced. And so we concluded from this that the nail works best when it is placed in the bone. This and a number of other observations have been published again in the JOT. And if you're thinking about adopting this technique, I would advise you to go and look at this experience of ours. So in conclusion, the fibular nail avoids many of the predictable complications of ankle fracture fixation, particularly in the elderly and those with compromised soft tissues, where it has an advantage over open reduction internal fixation. And we found that it is a safe alternative for other ankle and pilon fractures. That's the conclusion of my talk. I'm grateful for the organizers who have graciously allowed me to just mention a meeting that we're running in Edinburgh later in the year. It'll be the 34th Edinburgh International Trauma Symposium, which will combine a symposium for practicing trauma surgeons with debates and controversies, and an instructional course for trainees and those wishing an overview of orthopedic trauma from head to toe. Thank you very much.
Thank you, Tim. That was very, very nice. But would you like to answer that? Does this give you enough stability most of the time? Will the relative stability you get work?
Yes, so the answer is yes, it does work, because we have now done 500 patients and we've followed them up carefully and have reviewed and published those reviews to show that it does work without long-term complications. I think there is a misunderstanding maybe about the direct reduction and absolute stability. So in the early AO era, fractures had to be reduced open and then stabilized with absolute stability, because that by fixing the fibula in that manner, we were able to reduce the mortise indirectly. Now we reduce the mortise fluoroscopically, and that requirement to open the fracture no longer exists. So I think the concept that you require absolute stability is no longer relevant as a result of our improved imaging.
Okay. And the thing is that you've used this all in Weber A and B. You have any experience with some Weber C's or with complex fracture? I saw a pilon where you sort of used the nail. What is your experience with Weber C with the fracture much higher?
Yes, so we do use it for B's and C's. So in the distal third of the fibula, where we would tend to fix the bone and the syndesmosis, the device is perfect. Where there's a higher sort of meson nerve type fracture, we just tend to address the syndesmosis and not the fibula. But certainly, yes, for more complex ankle fractures and indeed for pilon fractures, where it's useful to minimize the number of incisions placed around the ankle, we found the fibular nail to be very useful.
Thank you, Tim. Last question from Balwinder before we go on to Ken. Balwinder, you have a question for Tim?
Sir, you already addressed it. So I was inquiring about high fibular fracture, that is type C. So you have, Dr. Tim, you have the locking screws, the locking bolts distally only in the nail. And if you have a ever C, then how do you stabilize it proximally? Because your screws are closer to the syndesmosis, so it is rotationally unstable, isn't it?
No, in fact, the position of the proximal fracture is probably irrelevant as long as the distal fragment, the lateral malleolus, is reduced and the mortise is reconstructed. Then the proximal fracture is irrelevant, as we know really from the treatment of meson nerve fractures, where we tend not to track down fractures in the proximal 2/3 of the fibula under any circumstances. There is a nice study that looked at the rotational morphology of the fibula, which I think is what you're proposing there. And there is a concept that the distal fragment externally rotates and needs to be rotated internally to produce an anatomical reduction of the fibula. Now, this axial scanning has shown, in fact, that that's not the case. The fibula tends to follow the talus. It's the proximal fragment that internally rotates under the action of the anterior and lateral compartment muscles. And so some rotational malalignment proximally in the fibula is not relevant, I don't think, providing the mortise is anatomically reconstructed and held.
Thank you. Thanks. Yeah, let's go to Ken now. Ken, can you share your screen, please?
Okay. All right. Can you guys see that?
Yeah, great.
And you can hear me. And I have no video in this, so I should be able to get through it. I'm going to talk about problems after ankle fractures and ways to manage them. Fortunately, most of these cases aren't my own, but I've certainly been there. My disclosures have not changed. So I'm going to basically go through malreduction of the mortise, talk about fibular shortening, the medial mal and syndesmosis, intra-articular hardware, articular incongruity, and soft tissue loss. I'll touch on all of those. There are a bunch of cases. I'm going to try and get through them pretty quickly. So the first case is a 75-year-old lady who presented more than a year at status post her ankle fracture repair with this. You can see she's got a fracture non-union of a fibula, a malalignment of the ankle mortise, and a widening of her syndesmosis. And you can see her plate actually broke in two places. So the key here is when you're reconstructing this and repairing this, that you have to restore fibular length. And that can be done very well with a device like this, a distractor. This is an ankle distractor made by one of the companies. But if you just go in there and try to fix the bone and try to squeeze that syndesmosis together without reestablishing length, it's not going to work. So that's done in this case. This is what it looks like in the OR. And this is what she looked like at 2 years. Again, she still was sitting in a little bit of hindfoot valgus, but she was comfortable, painless, and able to function. Now, similar case from, but this is an acute situation. A 50-year-old guy, twisting injury, undergoes repair of this Weber C fracture. And again, if I'm treating this, I'd probably fix the fibula and I'd fix the posterior mal, but we can discuss that later. Here's a CT scan showing, again, a very small shear fracture of the posterior mal. And undergoes this and returns to his treating surgeon 2 weeks later, again, with obvious construct failure, rewidening of a syndesmosis. And he came to me, and I think it's kind of subtle here, but you get the sense when you look at that talar tilt that this fibula was fixed short. And when it's fixed short, there's a tremendous amount of stress acting on this to displace the ankle mortise. So again, similar concept. If you're going to go back in, the key here is you got to take everything down, reestablish the length. Again, utilizing a distractor, a push-pull technique, whatever it is you want. As you lengthen the fibula, you'll push that talus back into its anatomic position. And in this case, we used a couple of syndesmotic screws. Again, if I was treating this patient from the beginning, I probably would have just put him prone and fixed his fibula on the back and the posterior mal, and that would have been enough without the syndesmotic fixation. You can see I had to overlap the plates here because there was none long enough in the set. And this you can do as long as you overlap and include fixation through the overlapped screw holes. And here's this patient at 2 years with a good result and a reduced ankle mortise. Here's another patient who was on vacation and broke his ankle, had this unstable ankle fracture, underwent repair and returned to the United States. He came with this ankle X-ray, and if you look at the AP and lateral, you can see his medial malleolus is malreduced. In addition, There's intra-articular hardware. One of the screws is penetrating the distal tib-fib joint. And this is one of the reasons I don't like using anything but a unicortical lock screw if I'm putting a lateral plate on the fibula. I could put unicortical, make sure I'm well short of the joint just in case. So this is an intra-articular malreduction of the medial malleolus and intra-articular penetration of hardware. This revision involves going back and revising all the hardware. And you can see, even on the lateral view, the medial mal looks better. And because it's a small anterior collicular fragment, I utilized a very small mini fragment screw and a suture tension band over a capstan screw proximally. And again, the key is the ankle mortise, because the outcome is 100% dependent on the position of the mortise at the time of healing. Here's a 14-year-old girl, a young kid who was injured in a sporting accident and was treated by a peds colleague of mine. And CT scan shows that this is really a triplane fracture pattern, but it really is behaving more like an adult ankle fracture. And she was certainly, in that age where, the distal physis is partially fused. So that pattern was considered a triplane. And this 14-year-old girl was treated kind of like a peds patient. And again, as we talked about, it's about the ankle mortise. And we all know if you don't have a good reduction, it's never going to get better after surgery. And this is the intraoperative image. And I would say that this is an inadequate reduction. The talus does not look centered on the plafond, and there's medial widening. Again, there's a malreduction of the medial side as well. And she was treated this way for a while, until this was seen in the office for follow-up. She was put in a cast just to immobilize her even more. But you can see the fibula is not reduced. And that posterior malleolar fragment there's an articular incongruity here. Here's the CT scan showing it. And although the screws are in the bone, they were never reduced properly. So you can put all the percutaneous fixation you want in, but I believe that the ankle mortise needs to be reduced anatomically. And this is what her skin looked like at the time. So that kind of limited what we could do. So in this case, I chose to take out the hardware and put her prone, again, going back, re-reduce that posterior mal, re-reduce the ankle mortise, and take care of the, take care of all the problems that way. I refixed the fibula anatomically. And again, you can see there's a reduced ankle mortise now. And she did quite well. Here's an interesting case. And again, this goes back to my whole feeling about the posterior mal. And this is a patient I got consulted about because he broke both ankles and ended up in our place on the rehab service. They wanted to know about weight-bearing, orders for this patient. And we got x-rays, and this is what it looked like. And you can just look at this plain x-ray and see that there's just something wrong. The ankle mortise doesn't look right. Okay, this was a Maisonneuve type fracture that the treating surgeon attempted to just repair with syndesmotic screws. And you can see on the lateral view that the fibula just doesn't look like it's positioned correctly. CT scan of the two ankles, if you look at where the fibula sits in the incisura, you can see that on the affected side, the side I'm concerned about, the fibula is sitting posterior, and it's gone posterior with the posterior malleolus, and it's fixed in that position. Now, we don't know what the normal side really looks like, but you get the sense that side had no syndesmotic fixation. The fibula was fixed. And you can see, if you look anteriorly where the tibia and fibula kind of have a Shenton's line, there's kind of a smooth reduction there anteriorly, even though it doesn't look absolutely perfect. So the solution for this was I took out the syndesmotic screws, and I treated this malreduced syndesmosis by just fixing the posterior malleolus. And again, by fixing that posterior malleolus and getting to heal at anatomic position, the syndesmotic ligaments healed in the correct position. And I'll disagree a little bit with my previous colleague. I do a intraoperative stress exam on every single ankle fracture. However, out of the last 100 prone ankles with posterior malleolar fixation that I've done, I've only had one that needed supplemental syndesmotic screw fixation. And that's because it was such a small fragment of bone. I wound up detaching, I believe, the PITFL in my approach to get to the fragment. So I think it was an iatrogenic syndesmotic instability that I caused. And here's this patient again at 1 year with an excellent outcome with an anatomically reduced ankle mortise. Here's another patient, also referred to me, again, a bad ankle fracture dislocation, HIV, severe diabetes, goes on, has this ankle fracture fixed. And, from my first two cases, you can kind of see what's going on here. It looks like, this was fixed a little bit short. And the ankle remains in a little bit of valgus. You can see on the lateral view, the fibula doesn't look like it's perfectly reduced. So the patient goes on to develop this with syndesmotic widening, and the treating physician went and said, well, one syndesmotic screw wasn't good enough, I'm going to do this, but never really addressed the fibula shortening, which I think was the real problem here. So even with these two screws, this patient goes on to fail. So it's, she's now about 4 months out. She's a two-time loser on this, diabetes. And so I decided to go with a syndesmotic fusion, which, in my hands has never been a great option, I'll be honest with you. And this is what I did. Multiple syndesmotic screws. I did iliac crest bone graft and tried to obtain fusion between the tibia and the fibula here. But, even my surgery didn't help. It maintained her ankle mortise, but, she went on to develop more symptomatic pain and just wasn't getting any better. I got a CT scan, which demonstrated that I did not have complete bony fusion, and she developed arthritis in her ankle joint. So at this point, we had a long discussion, and we just went for the ultimate salvage, which is an ankle arthrodesis. And, when all else fails, an ankle arthrodesis is a good solution for some of these more complex patients and injuries that do not respond to traditional measures. Here is an 80-year-old lady who had an open ankle fracture. You can see she was originally spanned in an external fixator, underwent fixation, but unfortunately presented like this at post-op with exposed hardware and skin breakdown laterally. And this is a big problem in most people. This is a very bad area for soft tissue coverage if you run into problems, but especially in the elderly. Bad skin, her fracture wasn't healed, and it was a bad location. Now, we have a lot of options nowadays for some of these problems, and problems can be, minor wound epidermolysis, blistering, full thickness breakdown, or complete infection. And the VAC has really helped our management of some of these severe soft tissue injuries about the ankle, but it can't do everything. So we call our plastic surgery colleagues. They have a lot of answers for us now: fasciocutaneous flaps, reverse sural, and these have all helped manage some of these wound problems where free flaps, are really not eligible. But in this case, we went with this, which was something we described and wrote a bunch of case series on, where in order to treat the soft tissue and close that wound primarily, we basically removed the fibula. And by removing the fibula, we then had to fuse the ankle. So here we used fusion of the ankle to treat the soft tissue. And again, this was the ultimate salvage for this patient. And here you can see her at 2 years, she healed and returned to normal life. So in summary, the key is the ankle mortise, and healing is really at the ankle mortise at healing is what really is related to functional outcome following ankle fracture. If there's fibular shortening, there will be talar tilt. And if you see talar tilt, there's something wrong with the length of your fibula, and that's got to be addressed, or else everything you do is going to fail. If you have a syndesmotic malreduction, think about the posterior mal. Go posterior, go prone, fix it. It's a great equalizer. And again, if all else fails, I believe that arthrodesis is an ultimate, although not perfect, salvage for any of these really crazy problems about the ankle. So with that, I will thank you and answer any questions, and I will stop sharing as of now.
Can you share your slides only, because we've got only 4 minutes left? So the ankle malunion discussion, we can take it on your slides. Can we go to your first case? Because we've got questions also. If you'll share your slides. Again,
okay.
Go to the first case. The first question which we've had asked is, the first case where your plate broke. Can you show that slide?
It's up, isn't it?
No, it isn't. You have to open the PowerPoint.
I have the PowerPoint open, and it says I'm sharing. So I'm going to stop sharing. And I don't know why it's on my screen. It's open.
Okay. Anyway, so the issue is, the first question is, why do you think that plate broke after such a long time? Was it established non-union or was it?
Yes.
Huh?
Yes, the patient had a non-union of the fibula, and eventually the forces of the fracture not healing overcame the integrity of the hardware. So eventually, if the bone never heals, all metal will fail and break.
Okay, so that also means that this was suprasyndesmotic. The syndesmosis also hasn't healed, and any talar instability which was there has also not healed. So that is a complex issue which has come up, because if the ankle mortise below it somehow stabilizes, this may not break. The next question which is asked is, how do you check for accuracy of fibular length and rotation at the time of surgery? Primary, not a malunion, but first time comminuted fracture.
Yeah. So it's difficult, and we've actually looked at that, and we've even found that using the intraoperative CT didn't really help us that much. But it's really critical assessment of your intraoperative fluoroscopy. If the other ankle is not injured, you may want to get some fluoroscopic views, especially looking at the lateral view and the position of the fibula in relation to the ankle joint on the lateral of the unaffected side. And that way you can compare your intraoperative reduction to the uninjured side while you're in the operating room. But it's really about length and looking at the ankle mortise, if you have, usually when you restore length, regardless of whether or not there's a syndesmotic injury, the medial clear space will not be wide. If you see widening before you put your syndesmotic screw in, and you think that you're going to close it down by putting the syndesmosis screw in, that's incorrect. It should close down by restoring length. If your length is correct, the only way your medial clear space should open is if you actually physically stress the ankle mortise.
Okay, thanks. I think we've got a question by Dr. Pradeep and by Dr. Sandeep. Sandeep first, then Pradeep, because we have time only for 2 questions.
My first question is, as you said that you can fix everything from prone, but that we want to know which are those fractures which you would not want to address it in a prone position. That is one part of the question. And how do you assess the syndesmotic reduction, especially if you are doing everything in prone? There are injuries, especially the Walkstaff injuries and the small chaput injuries, or those cases where the AITFL is problematic. There, a lateral position would be a much better position where you can actually juggle around and go a 360 degree.
So if my video had played, you would see that what I do is I put them prone for the posterior and the fibula, and then I flip them and reprep and drape to do the medial mal. Because I have found that trying to fix the medial mal from the prone position, while it can be done, it takes me as much time to do it as if I just put them and turn them supine. At that time, if there is an anterior Wagstaff fragment, I will make a small incision over that anterolaterally and fix that. I've done that. The only ones I won't fix the ones I don't fix prone are the ones that have no posterior involvement. So if it's an isolated fibula or a bimal that does not have a posterior mal at all to fix, I do not put them prone. But if there is any posterior injury that I can see, any bony avulsion, anything, I will put them prone and fix them. And I have almost, obviated the need to use transsyndesmotic fixation doing that.
And the posteromedial approach, the ideal case for you?
The things that you showed, when you have that separate fragment and there's impaction over there, I have a very poor experience in doing it. I do it, the x-rays look great, but I find whenever I do that approach and I retract the neurovascular bundle, I have a very high rate, not 100%, but I would say it's probably about 50% of people who end up with like a complex regional pain syndrome or severe, posterior tibial tendinitis, or something that involves the fact that I went back there and I disrupted the normalcy of that area. So I do it. The x-rays look good when you do it, but I've had some bad clinical outcomes associated with it.
Dr. Pradeep, your last question, please.
Yeah, I think a great talk, Dr. Egol. Just wanted to know your view. I've had a couple of cases where patients present almost 6 to 9 months after a missed syndesmotic injuries, and they start showing arthritis. What is your experience? Would you reconstruct them, or would you go for a fusion for them, or what is it?
Yeah, I honestly don't know what the right answer to that is. I would think 6 to 9 months later, I probably wouldn't try to reconstruct. I mean, when you talk about reconstruction, do you mean just putting screws in or doing the regular fixation, or you talk about some kind of graft to put in there. I think you'd probably have to do some type of graft if you wanted to reconstruct it. That's not in my toolbox, so I'd probably just do a syndesmotic fusion. But my experience in achieving a syndesmotic fusion is probably about 50%. Paul Tornetta writes about it and talks about it. He's got a much greater success rate in it, and he's very much pro syndesmotic fusion and on the bandwagon for it.
Yeah, so I had 4 cases, and it's really difficult to get that compression in spite of putting 3 screws over a plate. You still, as you showed in your case, you still can't get that enough compression, and probably if you get a CT done 6 months later, you'll still see a gap, though maybe be clinically asymptomatic, but still you've not achieved a fusion. Is that your experience?
Yes.
Yeah,
Thank you.
actually here the key to do a good syndesmotic fusion again is to go in a lateral position, simultaneously open the anterior part of the syndesmosis. We have done a couple of syndesmotic fusions. They work good. The joint preparation is the important thing. Just open it from the anteriorly, the syndesmosis gets open, and then fuse it. And other options also, we have done some ligament reconstruction also in delayed cases, but then they are difficult cases and you cannot predict results exactly.
Still have to show
Okay.
We have to show a longer follow-up on that on the ones which would. Anyway, thank you guys. I think we bring to an end the ankle session, and we'll go on to the talus, and we'll start with Dr. Tim White, who's going to be talking about fixing the complex talus fracture. May I request Tim to start his screen sharing, please?
Dr. Dhillon, sorry, give me 2 seconds. That talk just seems to have
it doesn't matter.
Itself down. I'll just reopen that.
Chat about things. It's not a problem, because in the talus we've particularly tried to get just 3 talks in. With one is fixing the complex talus fracture, and second is when should we use the posterior approach? Because I've seen in India there are still many surgeons who are using the posterior approach even for fractures of the neck which are interior, and that leads to so many problems. And thirdly, again, a problem which is unique to the underdeveloped world is neglected talus injuries. Okay, we've got Tim back with us. Thank you, Tim.
Okay, thank you very much. So moving on to talar fractures, I think in a nutshell, there are 3 principles here. This is a severe hindfoot injury. There's a tenuous blood supply to the talus, and complications, particularly vascular necrosis, are common. And a lot of these relate obviously to the anatomy of the talus. And my predecessor used to enjoy saying the talus is thrice remarkable. And this is obviously due to the fact that 2/3 of it has a cartilaginous surface, there's no muscle or tendinous attachment, and it has a tenuous blood supply from the 3 vessels of the ankle, communicating through the artery of the tarsal canal, and with this retrograde supply from the neck into the body. So talar neck fractures are classically thought to arise principally from forced dorsiflexion, where the neck impinges on the anterior edge of the mortise, although of course other torsional mechanisms also exist. Classification by Hawkins breaks these down into those that are undisplaced, those where the neck has fractured and the body has rotated, resulting in displacement of the subtalar joint, those where the body has moved further and the ankle joint is displaced in addition, and those where the talonavicular joint and the head of the talus have also displaced. And these are important, of course, because they give some idea of the risk of avascular necrosis, which is high. So management, first of all, if we're aiming to protect the soft tissues, ideally in the emergency department, we want to reduce an extruded body, and this reduction maneuver is worth appreciating. So the knee is flexed to take tension off the gastrocnemius. There is longitudinal traction, dorsiflexion, and then eversion to allow the medial malleolus then to be pushed in by the examining hand. This can be done in the operating theatre with the additional use of a denim pin through the calcaneus to allow additional traction to be applied. Now, there are some situations in which there is extremely vulnerable and contused skin, or indeed excessive soft tissue disruption, in which urgent talar reduction and fixation is just not possible. And in these situations, we're going to temporize with an external fixator and come back later once the soft tissues have been salvaged or reconstructed to reconstruct and fuse the skeleton as required. But let's go on and talk about those where operative fixation is going to be feasible. So our aims of surgery are to preserve that tenuous blood supply of the talus where there is some residual vascular structure. We want to preserve the length of the medial column of the foot. And this is at risk if we fail to consider things carefully. Firstly, OIF, which is open reduction and fixation without going through the tedious requirement to reduce the fracture, can result in a loss of length of the medial column and a misshaping of the foot, which then overloads the remaining joints of the tarsus. And overcompression, which can occur with longitudinal placement of screws. And we'll come on to that in just a moment. And of course, we want to achieve this whilst avoiding soft tissue complications. And this is achieved by considering minimal access and the use of dual incisions. So thinking about incisions medially and laterally on either side of the talar body and neck. The lateral incision at the top here being shown just lateral to extensor digitorum longus tendons, and the medial incision at the bottom there shown just medial to the tibialis anterior tendon. These approaches can be augmented by the additional osteotomy of the medial or occasionally the lateral malleolus and the occasional additional use of posterior approaches. Fixation largely comes in three potential flavors, from front to back, from back to front, or from plating. And this is where loss of length is important, because these first two, although attractive in the simple fracture line, do allow the fractures or do result in the fracture in being compressed. And that results in loss of length of the talus and loss of length of the medial column. And so for complex fractures, we're looking really at plating techniques on the far right of the picture there. So let's look at a case. This 24-year-old girl fell from a horse, getting her forefoot tangled up in the stirrups. The axial pictures don't look too bad, despite some comminution, but the sagittal pictures show the displacement and that area of comminution. So I approach this fracture from medially and laterally using those two incisions that we looked at before. This is the medial side, and what we can see here is the medial aspects of the body of the talus, the fracture itself, and then the head of the talus here. After fracture reduction, you can see that the fracture gap is reduced anatomically, and I've just held this temporarily with a percutaneous K-wire that you can see just at the top of the picture there. This is what we see through the lateral approach. And if we come in a little bit more closely, what we can see here is the dome and body of the talus. There is an area of substantial bone loss here, extending down towards the tarsal sinus here. And then the head and neck of the talus more anteriorly there. So this area of comminution and bone loss is going to compromise our ability to reduce this. And the process of reduction is often somewhat iterative. One can reduce the medial side and then go around and look at the lateral side and find that it's not perfectly displaced. And then you can adjust that and perfect it, and then go around to the medial side and find that something has become displaced on that side. And it's often a case of going carefully backwards and forwards a few times until the rotational and axial alignment of that fracture is perfect. And then once it is, and it's temporarily stabilized with K-wires, it's possible to go on and consider definitive fixation. So there's that fracture reduced and again held with a K-wire. And fluoroscopy allows us just to confirm what our eyes have already confirmed, which is that the fracture is reduced. And in this case, you can see I've got two 1.6 K wires there across the fracture, and I've used this rather larger 2mm wire into the dome of the talus to allow me to use that as a joystick and position that optimally so I can bring the fracture edges together. So a useful to have a joystick and then fixation wires. Okay, we then move on, and I've used medial and lateral plates here. Now, the size of the plate here is a 2.0, 2 millimeter compact handset plate, a simple plate on the medial side, a T plate you can see there on the lateral side. And there's a gap here resulting from comminution and bone loss that we discussed earlier. So screws into the head of the talus and into the body. On the medial side, the fracture was straightforward and simple and has been compressed and has largely disappeared. On the lateral side, this situation was rather more complex, you will recall, and I filled this with bone graft and then a small section of cortical bone to complete that. And then this plate has been used largely to bridge across that fracture and to hold this bone graft into place. And that's the final construct. And there it is at 2 years, having survived and avoided avascular necrosis. Outcome is really excellent, as you'll see from this. Only a minority of patients have an excellent result. There are some good and moderate results for the undisplaced fractures, and by the time we come to Hawkins 4 fractures, almost universally outcome is poor. I've got a couple of other cases just to illustrate, first of all, that anatomical approach. Here's at the first sight a less severe talar fracture, and what we see here is not that the talar neck is intact, but the head has been compressed, and in fact a fragment here has been extruded. And what you might expect from that CT scan is what we later found, which is that the articular surface of that talar navicular joint has largely been destroyed. So we've got a destroyed talar navicular joint, which is unreconstructible in terms of preserving that as a useful articulation. But more importantly, if we think about this medial column concept that we touched on earlier, we can see that the loss of this area of the talar head has allowed the foot to become banana-shaped, placing stress on the lateral side. And that's a highly unstable midfoot, which requires to be stabilized. In this situation, that same approach that we looked at before, just medial to tibialis anterior, is taken to expose the body and neck of the talus. There's that small extruded damaged fragment. And once that's removed, this cavity is seen here between the cancellous surface of the talar neck and head and the navicular. And in this situation, I've done a primary debridement bone graft and then fixation and fusion across that joint to preserve the length of the medial column. Okay, one more case just to illustrate that some of these fractures are really unsalvageable. Here's one that was referred to us from a different hospital. Clearly a devastating injury. It was open at the lateral side. The talar body has been fractured and extruded, as you can see there. And the treating surgeon on the night of admission decided to put on a bridging fixator and then play kerplunk with those pieces. Unfortunately, this did not result in adequate reduction or stability, and the wound also began to leak. And so these fragments required to be taken out, as I think they might have been at the time of primary surgery. And we've performed a direct fusion between the calcaneus and the talus with a retrograde nail there. And that healed up well. The patient was left with a slightly short limb because of the loss of the talus. And so he then underwent nailing at the top end and lengthening, and has gone on to a solid union then of his limb at the correct length. So in conclusion, this is a severe hindfoot injury. There's a tenuous blood supply to the talus, which results in a high rate of complications, particularly avascular necrosis. Thank you very much indeed for your time.
And while Siddharth, I think it's Siddharth next, if I'm not wrong, loads up his slides and share the screen, can I ask you one or two of the questions which have been asked by the audience? How common, in your experience, is bone loss on the undersurface of the talus? Because some people say that they get a significant loss of bone on the undersurface, on the bottom of the neck. And does that compromise subtalar, the joint later on? We all look at getting the medial length right and getting the rotation right. What about the, some kind of loss on the undersurface?
Yeah, no, you're quite right. And in fact, that case where I bone grafted and bridge plated is an exact case in point. There was extensive damage to the bone there. Now, my view on that is that because of the artery of the canal, I don't like to go debriding and dissecting in that region, because I think that probably is one of the few areas of blood supply that might be left to that talar body. And so my view is to try and maintain length as you saw there, with reduction and grafting as required, and then bridging. But you're quite right. That comminution is usually circumferential, medial, lateral, dorsal, and plantar.
Thank you very much. We have a question again, but we'll talk about it at the end of it, about the type 4 talus neck fractures. But we'll go on with Siddharth now and hold that question till the end of the session.
Sir, are my slides visible and am I audible to you?
Visible, go on.
Yeah, okay. Thank you. So we heard Dr. Tim speak about the complex talar neck fractures, and he told you that dual approaches are the key for these fractures. Now, in a small subset of cases, you may need to do a posterior approach to the talus, which is what my talk is about. And we will be looking at the when, that is the indications, why, like why would you do these approaches? What are the advantages? And how, which are the technique basics of the posterior approaches to talus. And all of these are case-based approaches. So let's look at the indications for posterior approaches to the talus. The first and the foremost, although not so common, are the posterior tubercle fractures, which are essentially intra-articular fractures of the subtalar joint. You also have the medial tubercle fractures. Now, mind you, these are extra-articular fractures, but from the knowledge of anatomy, you know that the tendon of the flexor hallucis longus is just behind this, and you have the neurovascular bundle running very close to it. So when you leave these fractures unaddressed, they have the potential to cause irritation of the FHL and also neurovascular problems. So you often need to fix them or excise them, depending upon the size. And very rarely, you also have fractures of the posterior talar body, where the major fragment is posterior. So of course, you cannot approach them from the front. You cannot even see them by a medial malleolar osteotomy. You have to approach them by the posterior approach. So like I said, posterior approaches have the advantage of letting you see the fragment, directly. You cannot really fix them from anterior to posterior. You can go in and have fragment-specific fixation. You can use screws, plates, or even lost K-wires. And I'll also show you a case where a subtalar fusion was done by the posterior approach. So these approaches let you see the subtalar joint. If there are loose fragments, you can do a lavage. And of course, you can also use them for subtalar fusion, though not as commonly as the routine sinus tarsi approach. So let's look at these approaches one by one. So there are three major approaches. The workhorse approach is the posterior-medial approach, which utilizes the interval between the flexor hallucis longus and the Achilles tendon. So the Achilles tendon is retracted laterally, and the FHL, along with the neurovascular bundle, goes medially. It protects the neurovascular bundle. The other common approach is the posterior-lateral approach. Now, mind you, this is an extension of the posterior-lateral approach to the ankle. You have to come down. The plane is between the peroneal tendons and the Achilles tendon. And then also described in the literature is the Achilles tendon split approach. Not a very common approach, but you can split the Achilles tendon right in the center and go right to the middle of the talar body. So the posterior medial approach is the workhorse approach, as I have said, and here is a case which shows you this approach. So this is a 25-year-old gentleman who fell from height. He had a medial subtalar dislocation, as you can see in these x-rays. Closed reduction was done elsewhere, and the surgeon at that point thought that this was a small associated posterior process fracture. And he thought whether we should conserve this or operate this. But when we did a CT scan, you can see that this is not a small fragment. In fact, this is extending into the posterior part or the posterior medial part of the talar body. And even in the sagittal sections, you can see that this fragment is extending into the subtalar joint. If you leave this as such, it has the propensity to cause subtalar arthrosis and late subtalar instability. So this needs to be fixed. And again, looking at the 3D pathoanatomy, you will note that the patient had a long Steedas process. In addition to this, they had a posteromedial fracture. So the positioning for the posteromedial approach is, of course, in a prone position. You put a big bump under the ankle. And in this case, I started by pinning the subtalar joint because I did not want the joint to dislocate. So there is the subtalar joint. It has been pinned. And this is the skin incision. You place it midway between the Achilles tendon and the medial malleolus. You do a vertical dissection. You don't want to raise any unnecessary skin flaps. Once you do that, you see the inferior flexor retinaculum, which you divide sharply. You identify the tendon of the flexor hallucis longus. Now, this is the only tendon which is all beef right up to the ankle, and you can identify this very easily. So you dissect lateral to the tendon of the flexor hallucis longus. The FHL goes medially. The tendo-Achilles goes laterally, and the FHL, when you are retracting it, you are also retracting the neurovascular bundle. Now, Dr. Egol, brought out a very important point here. When you are retracting the FHL, make sure that you have a good exposure. Do not go into the belly of this because the patient would have clottos postoperatively. And here you can see that there is a good exposure of the talus along with the fracture fragments. So provisional reduction was done with K wires, and then definitive fixation was accomplished by means of screws in this case. So after fixation, you can see that the fragment is pretty stable. And here is another useful tip. If you want to see more of the back of the talus, just dorsiflex the ankle and distract it a little bit. You'll be able to see much more of the articular surface. And another bit is if you had fracture of the posteromedial process and you wanted to see the fragment involving the FHL groove, you have to release the pulley of the FHL tendon and retract it out of the way, and then you will be able to see that fragment. So here definitive fixation has been done. This is the immediate post-operative X-ray. The K wires were removed at 4 weeks. This is the 6 months follow-up, and this is the patient walking painlessly at 6 months, and he has had a good outcome. So here is another case, a 32-year-old male with a road traffic accident. This was an irreducible medial subtalar dislocation. And on the 3D reconstruction, you can see that they have a lot of comminution of the posteromedial side of the talus, as well as a posterior process fracture. So the irreducibility in this case was because of the buttonholing of the talar head through the extensor digitorum brevis. So we had to give an incision, divide the EDB, and then the talus was reduced. This has been pinned. Coming on to the posteromedial approach, you can see that this is a big posteromedial fragment, which was fixed with screws and some K wires. And this is at 2.5 years of follow-up. So this patient did have subtalar arthrosis because of the high velocity mechanism of the injury, but otherwise they have good dorsiflexion, plantarflexion, and he's doing well. So how about the posterolateral approach? Now, mind you, with your workhorse posteromedial approach, you can see a lot of the back of the talus, but this is one case where I did the posterolateral approach. So this is a 40-year-old female. She gave a history of ankle sprain, a doubtful injury, which was like an ankle sprain 8 months back. She was tender right at the back of the ankle. The subtalar joint was tender and the movements were also painful and restricted. So when you do on the X-ray, you can see that there is a lot of exostosis going on at the back as well as subtalar arthrosis. So the CT scan confirms that this patient has a long posterior process as well as maybe a doubtful fracture with exostosis and a clear posterolateral impingement. The MRI also confirms the findings of the posterolateral impingement. So in this case, the three problems were the Steedas process with a possible fracture and exostosis, posterolateral impingement, and for this you would need to excise the process and debride the osteophytes, and you also have the subtalar arthrosis, which would need subtalar fusion. And because all of this was posterolateral, I chose the posterolateral approach. Now this has already been covered. So this is the marking, that's the skin incision, and as you go to the talus, you can see that those are the exostosis and the long process. So after the debridement, the joint looks okay now. You put in a couple of wires in the talus and the calcaneus and use a Hintermann distractor to distract the subtalar joint. And you can see the visualization of the subtalar joint really well, even with this approach. The subtalar joint was prepped and then hardware was put in. Now, in this case, I would have wanted my screws to be a little bit like this, but it is what it is. And at 2 years follow-up, you can see that the joint has fused well. This is the latest follow-up. She has a good range of motion at the ankle and she can walk painlessly. She is a happy patient. So moving on, the Achilles tendon splitting approach. Now we use this commonly for Achilles tendinosis and calcific tendinosis, but I have never used this, but just to complete the discussion. So here the incision is midline, the Achilles tendon is split in the middle. You can see the back of the ankle. You can use ankle joint distraction to see the fracture or to grip the joint, whatever the indication may be. But this is not something which we use routinely. So what are the outcomes of the posteromedial approach? Now, mind you, there is not much literature on this. There is this paper from Michael Swords et al. Where they did this approach in 10 fractures. All of them were intra-articular at the subtalar joint and the ankle joint. They got union in all the cases. The ankle range of motion was 80% of the contralateral foot. The subtalar range of motion, however, was decreased. This may be due to the high velocity mechanism of the fracture itself and not the approach per se. Most importantly, these guys did not require any secondary fusions at a mean of 4.8 years. Now, we've also run about 8 such cases and our results have been similar to those of Michael Swords. So to sum up, the posteromedial approach is the workhorse for most posterior talus fractures. This is a straightforward approach, but you need to get familiar to the position as well as to the anatomical landmarks. The posterolateral approach, although you can use it rarely, but this gives you a very, very good visualization, especially when you have posterolateral impingement. The Achilles tendon splitting approach, although it finds a mention in the literature, is used rarely. I never use it in my practice for posterior talus fractures. Thank you. And I'm going to stop my screen sharing now.
Thank you, Dr. Siddharth. And while Dr. Manut is bringing on his screen, we have a couple of questions, and the faculty is also welcome to ask the questions. What about your, do you think you have an experience or would you recommend the posterior approach for fixing talar neck fractures, type 2, type 3, which have been reduced? Would you like to fix them from the back? Because there's this very famous study in the JBJS from the 1980s, which show that biomechanically the screws put from the back are good or better for stability of neck fractures.
Yes, sir. I'm aware of the study. Even in 2020, they are doing studies to show that biomechanical constructs from the back are better. But when you have dual approaches, which are the standard of care, and Dr. Tim has already shown you, you have excellent visualization of the neck. I don't think with a posterior approach, you can visualize the neck at all. So you are inviting trouble if you do an approach in that case. You have malreduction. And as Dr. Tim has said, malreduction is not tolerated well. You need to maintain the length of the medial column. You can only do this by a medial approach. So a posterior approach for a talus neck fracture is a no-no for me, absolutely.
Any comments from Tim about this?
Yes, I think I would tend to agree. I think the only situation in which I've done a posterior percutaneous fixation is in a situation where there's a body fracture that is undisplaced purely to allow the patient earlier mobility. So it's a fixation of the undisplaced fracture. But I agree, where there's displacement, I don't think I can reduce that closed from the back. And I certainly don't think I can keep the length, which is probably the more important part. So yes, we have consensus there.
Yeah, in my younger days, when I was a more aggressive surgeon and with that more black than white hair, I have used 3 approaches to fix complex talus fractures. I like to show them around in my talks that we did the talus neck fracture from dual approaches, and then there was this huge fragment of the body at the back. We flipped over the patient and fixed it from the back. Do you think that's a bit of an overkill today? Would you like to do them in one stage, all 3 approaches, or maybe one at a time? Any comments?
I would still do all 3 of, I would still do all 3 of them together, because if it was a big fragment at the back, that would be going into the subtalar joint. So I would not take any chances for late subtalar instability or arthrosis and do all those 3 at the same time. Dr. Tim.
Yeah, no, I have nothing more to add. I agree completely.
Okay, thank you. Dr. Pradeep. it's your ball game now.
Thank you very much. Thank you. So following from both Tim as well as Siddharth, which has made my life slightly easier, but not a very common injury. So let's start with the case. A 15-year-old boy had a history of injury to the ankle. And these were the x-rays. He complained of pain and swelling of the ankle and unable to weight bear. And he went almost couple of 2 or 3 surgeons. They thought that there was no fracture. Finally, he had an MRI done, which showed there was a talar neck fracture, which was slightly displaced as well. And finally, he had a close reduction and a screw fixation done for this injury. He was kept in a cast for 6 weeks, non-weight bearing for almost 3 months. He presented to me almost 6 to 9 months after the injury, where he continued to have pain. He was walking with a limp. He was walking with a slightly walking on the outer lateral border of the foot, and you can clearly make out he was not a happy patient. Got a CT scan done. You can see this is the normal side. This is the abnormal side. There is definitely a change in the neck of the neck alignment of the affected side. You see the sagittal, and here you can see clearly this. There is definitely a dorsal angulation as well. Something is happening, and here this screw, the second screw, if you see, it is going into the almost going into the subtalar joint or the soft tissue as well. So question is, what went wrong? And let's go through some little bit of literature, maybe a slight overlap from the previous speakers, but still worthwhile. Talar's fractures are not very common. They are less than 1% of the whole fractures of the body. But this is the second most common tarsal fractures. And usually it is because of high energy trauma. And you can say that talus is almost like a bony meniscus, where there is hardly any attachment of muscles into the talus, surrounded by a lot of surrounded by a lot of muscles and tendons. It is a junction. It acts as a junction between the lower leg and the foot, and talus is covered by almost 60% of cartilage tissue. Mechanism of injury, which has gone through it. So it's a dorsally directed force where there is a cantilever acting at the neck, and there is a neck fracture. And if the force continues, you have a subluxation and a dislocation present. But the key thing which you can understand from the whole anatomy of the talus is that getting a anatomical reduction is the key. If you do not get that, this is what happens. So Sengrojan, from 1992, he did a research or studied 7 cadaveric patients and looked at varus malalignment of the talar neck and what are the joint forces happening on the posterior, middle, and the anterior facet. So here you can see the contact pressure prints on the posterior facet. Here that's a normal contact pressures. If you do an osteotomy and he did a fixation, anatomical fixation, it was almost normal. And if there was a medial displacement of the neck, the pressures increased on the posterior facet. But the key thing to understand is look at the anterior and the middle facet. What happens? In the normal and the anatomic reduction had a normal footprint. But if there was a medial rotation of the neck of the talus, there was no contact in the anterior and the middle facets. And this is what they concluded, where if there is a rotation of the neck of the talus, the anterior and the middle facet literally offloads and significant pressure increases in the posterior facet. So even a 2 millimeter displacement caused all this stuff, and thereby suggesting that anatomical reduction is a key. Even more than 2 millimeters malalignment is not acceptable. Hence, looking at the literature, we found that malunion is common, ranging from 10% to almost 67%. And you can divide the malunions into talar neck and the talar body. Now, the topic is neglected talar injuries. So why do we have these kind of neglected? Either it is a failure to recognize the displacement as seen in my first case. Is there an adequate reduction of the talar fracture? In India, we see very common either the patients do not seek treatment or they come at a very delayed stage, thereby leading to malunion, non-union, and even arthritis. If we see talar neck fractures, we know the fact that usually there is a medial side comminution present. So if either they are not treated or they're treated inappropriately, the talar neck goes into a varus. So there is a shortening of the medial column, thereby leading to hindfoot varus and internal rotation with a forefoot adduction. And these all thereby leading to reduction in the movements of the subtalar joint and the mid-tarsal joint. If you have a malunion of the talar body can be divided into either a central, which is the main body of the talus, or peripheral fractures, which are usually the lateral process and the posterior process. The central, the talar body is usually fractured because of the axial load, while the lateral side of the posterior is because of the shearing loads. And these can present with pain, instability, or deformity. And the deformity could be either a varus or a valgus. So that needs to be understood when you're treating these kind of patients. Non-union is not very common. The incidence is only between 2 to 3%. But if they are inadequately treated, then the incidence can go up to 12%. And usually these patients come with pain, incongruity, arthritis, and restriction of mobility. Avian, usually it is not because of the delay in the treatment. It is the avian is mainly because of the initial displacement at the time of injury and the severity of the injury. The avian, we know now that it does not depend on the delay in the treatment. That means you do not need to treat the patients within 24 or 48 hours of the injury. The key to treating these neglected injuries is a very, very thorough assessment of the patients, whereby you assess the kind of deformities they have, if they are painful or not, if the deformity is rigid or if it is flexible, and if the hindfoot is in varus or it is in neutral position. You always assess the patient on the weight bearing from the back, the front, and also look at the plantar side to see if there are any painful callosities as well. Check for range of movement of the ankle, subtalus, and the midfoot area as well. And along with it, check for soft tissue, especially if these patients have had open injuries or have had previous injury. Then you need to know what type of approaches you're going to use and what is the skin condition. And of course, last but not the least, check what are the comorbidities of the patient, if they are tobacco or a smoker, diabetes, any peripheral vascular disease as well. And radiographic assessment is key in these patients. These patients definitely need thorough assessment in terms of weight bearing, AP, dorsoplantar, lateral views of both the foot and ankle. Also need a hindfoot or a Salzman alignment view, which is a standing view. Also, canal view is helpful, whereby it gives you a good assessment of the talar neck, but you cannot completely depend or decide the treatment protocol through the canal view. I think the key thing is, if you're planning for any surgical intervention, then CT scan is mandatory. And I would suggest, like all my CT scan, I get them at a 1 millimeter cut, because you can reconstruct or do a 3D reconstruction of the whole images, the raw images, as well as if you're planning to do any 3D printing, then you need a 1 millimeter cuts definitely. The 3D CT scan is helpful in the planning of your surgery, as well as to see if where are the joint incongruities and if there is significant arthritis or not. Also, MRI scan is also mandatory to check if these patients have avian. If there is avian, if it is less than 1/3 or more than 1/3. Also looking at the joint surfaces as well, and any tendon pathologies as well. You can, if you have access to it, get a SPECT scan done to see if which part of the joints light up and the amount of degree of arthritis present as well. Zwepp and Remard has classified these kind of injuries into 5 stages, and the key to understand is divide between 1 to 3, which is together, where these kind of injury or these kind of joints or malunion, you can do a reconstructive surgeries, while 4 and 5 you are looking at some salvage options. So 1 is you have malunion with joint displacement, and 2 is non-union with joint displacement, 3 is with a partial AVN. So what are the treatment options if you have? If you're looking at doing some surgical intervention, the key is either are you going to do an anatomical reconstruction for these patients, or are you going for a salvage procedures? And it really depends on what are the patient factors and the radiographic assessment. If the patient have significant pain and deformity, and there is minimal or very early OA with good bone stock, no infections, then these patients are amenable for reconstructions. If the patients have the skin tissues or there is infection, skin tissues are not very good, significant avian, or a non-compliant patient, or if you have osteoporosis or immunocompromised patient, then these patients probably are relative contraindications for doing reconstruction or even kind of surgery. So you really need to weigh your options, sit down and talk to your patients. What are the best treatment options available? And here again, Remad has given treatment options depending on active, reliable patients and non-active or non-compliant patients. And you can see 1, 2, and 3 here. You can see an osteotomy or reconstructions you can do, while fusions are the other options if you have non-compliant patients. If there is a complete avian, you're doing a total or a partial talectomy along with bone grafting and a fusion. And if there is infection, you do a debridement there and you do carry out the further procedures. Before you endeavor on doing surgeries, and you need to plan these patients. And the key is, as I said before, these patients will need a dual approach. Look at, and when you're doing your surgery, also always prepare the iliac crest, because you will need a good tricortical chunk for the bone grafting of either malunion or non-union. Check where the old scars are there, and can you use these scars in your second surgery as well. If the patient has had surgeries before, then you need to remove the hardwares completely and then decide on the surgical planning. Especially when you're doing a dual approach and previous surgeries, you need to avoid stripping the dorsal neck vessels and also take care of the deltoid vessels, because these will be the only blood supply to the talus. A femoral distractor may be very helpful if you definitely to look at the joint surface and get help in the reduction of the either non-union or the malunion. You need to expose the previous fracture site or the non-union site, debride it, freshen the edges, and then depending on what you're doing, either if it is a malunion, here where you're opening up the non-malunion site, put a K-wire, freshen and do an osteotomy. And here you can see how the foot was supinated by opening up with your hinterman, how it is not just opening up on the medial side, you're also rotating the foot into a normal position. So it is just not a medial opening wedge osteotomy, but derotation of the forefoot to correct the deformity as well. Once you have done that, you need to put a tricortical bone graft, and a stable fixation needs to be achieved, which usually in terms of, you can use it a positional screw. These are not compression screws, but positional screws, 2 or 3, and even a small 2 or 2.7 millimeter plates can be used. Here you can see how the medial side osteotomy has been done, opened up, and then you put a wedge tricortical graft to be put in. If it is a tailless body you need to approach, most of the times you need a medial malleolar osteotomy, which can be done either a chevron based osteotomy, and you can get a good access to the talar body as well. Lateral process fractures, I think Siddharth has covered very well. In the old cases, either if it is usually these kind of lateral processes need excision, or if it is too large and there is minimal subtalar arthritis, you can go for a fixation. Again, posterior process, depending on the symptoms and depending on the size of the fragment, you can either go for a excision or a fixation. And in the approach, of course, do take care of the sural nerve. Along with the these procedures, sometimes you need other procedures where if either the hindfoot is in significant varus or valgus, you may want to think of doing a calcaneum osteotomy, or if the joint surface is inclined, then a supramalleolar osteotomy may be required. TL lengthening or gastrocnemic resection may also be required. If the patients have severe arthritis, or the tissues are not amenable, or the patient is not amenable for reconstructive surgeries, then you're looking at salvage options like arthrodesis of either ankle, subtalar or talonavicular joints. Sometimes in old talar neck fractures, there's no other option but to do a triple arthrodesis or a TTC fusion with talectomy. Ankle replacement may be an option as well. However, before endeavoring any form of surgery, even if you think that a joint reconstructive surgery is better, patient needs to be counseled before the surgery that if the cartilage or the condition of the joint is not very good, a fusion may be a better option. So this discussion has to be done before any form of surgeries. So some cases, so we looked at that first boy of 15-year-old. He initially, I thought, was getting irritated by this screw So instead of giving him a full derotation osteotomy and doing all the things, initially I just removed this screw from that subtalar joint, debrided the subtalar joint, just freed it up, gave him an orthotics, and he is quite a happy patient. Another patient, a 32-year-old lady, treated 9 months back for a fractured talar neck, and she came with pain and swelling in the ankle joint, unable to weight bear. And here you can clearly see there is a significant non-union of the talar neck. Bloods were normal. There was no evidence of infection. I got a CT and an MRI done, which showed that the joint was not significantly arthritic, and we could still salvage the joint. So finally, these were the pre-op pictures, and here you can see the healed previous scars. So those scars were used. All the metal work was removed, kept the medial malleolus intact. Tricortical graft was put in, and finally, fixation of the talar neck was done. Third case, courtesy of Dr. Balwinder Rana, thank you very much. Again, a patient with significant injury, closed injury to the talus. This was immediately post-op done by the primary surgeon. And here you can see, I don't think so they have got any anatomical reduction of the talar neck. And worst case, even the screw which is meant to be in the talus is not there, it is outside in the gutter. And she came 6 months post-operatively, wheelchair, not able to put weight on it. Finally, a medial malleolar osteotomy was done, dual approach, a distractor which we have already mentioned, subtalar reduction and fusion was planned, iliac crest was used for the neck non-union, and multiple screws for the talar neck. This is 10 weeks after the surgery, after a subtalar fusion and anatomical reduction of the talar neck. And this is a 2-year follow-up results. Patient has done extremely well. Another case, this lady came almost 2 years after her talar neck injury with pain and swelling. And this was way back in 2016 or so. She was managing quite well. So I thought that let's conserve her. A year later, she came back, increasing pain, increasing arthritis, both in the ankle and the subtalar joint. So finally, I did a hindfoot fusion. And 1 year later, she's done quite well and she's managing extremely well. So what are the outcomes for these kind of reconstructive surgeries? So there are not many...
you have to wind up, please.
Yes, last 2 slides. So not many surgeries, Chang and Ramal surgery, they have done quite well with the reconstruction. Salvage organ options, only 11 and 5 and 7 smaller studies, and they have done reasonably well as long as the patient are counseled properly. So in summary, these are challenging problems. Surgeons should be aware of various salvage and reconstructive surgeries, investigate them properly, and the best is to get it right the first time. Thank you very much.
Thank you, Dr. Pradeep. And we have some questions as we go along. And then maybe, I don't know, I think I have 5-6 minutes to show a complex case. Okay, one question is about the definition of type 4 cases. Now, that's probably addressed to Tim. And also Pradeep said that it's a dorsiflexion injury of that's what causes the fracture of the neck of talus. So what causes a type 4 fracture? If you got a dorsiflexion injury, which is controversial because it was the aviator's fracture and the neck of the talus was supposed to hit against the anterior distal tibia and cause the fracture going on to the subtalar dislocation if the injury continued. Now, how do they get a type 4 fracture, a dislocation of the subtalar joint? Who's going to take this on?
I can give you the answer that I don't know. I think trying to predict or trying to work out what happened at the moment of injury is a notoriously inexact science and makes astrology look respectable. My favorite paper I ever heard at the OTA meeting was done by a group from Boston, and they looked at the Lauger-Hansen classification for ankle fractures, which we assume we know all about, and the position of the forefoot and the way the ankle rotates at the moment of injury. And they got a group of people who'd posted their skateboard accidents on YouTube and got them to send all their x-rays in. So they then compared the x-rays with a video of the accident actually happening. And there was no correlation between the Loger-Hansen classification and what they could see at the time of injury. And that's the one that we really think we understand. I think all other mechanisms of injury are purely guesswork, and I have no way of working out the what happened, I'm afraid.
Yeah, I can take a call on this because few years ago in a Davos AO course, again, exactly the same question was put up. And Les Grujic from Australia said that he knows of a study in Australia where they tried to do a dorsiflexion injury and they could not actually cause this talus fracture. And I personally believe, because I have a little interest in type 4 fracture, there's an element of torsion involved, which actually the talonavicular joint would have to be necessarily something like a midfoot injury or something like that. That's why the head and neck of the talus sort of rotate out. So there has to be an element of midfoot injury over there, but that's okay. That's beyond the talk over there.
Sir, can I make a comment?
Yeah, start. Yeah,
I like a quick comment. So in addition to a dorsiflexion mechanism, now we also know that inversion is also a very common mechanism. That's why you have comminution on the compression side, which is medial, and the tensile side is lateral, which is more or less intact. And with these kind of inversion injuries, we know that medial subtalar dislocations are common. So the same mechanism can also possibly result in dislocation of the talonavicular joint. And in fact, sir, you and me also, we have seen in many type 2s and type 3s, there is an instability of the talonavicular joint that you have to address with K-wires. You have to pin the talonavicular joint. So it's not very hard to conceive that it can get dislocated completely if that inversion force continued. That's my take on it.
Chicken and egg story. What happens first? If you break the talus neck, then you can't dislocate the talonavicular joint. So I mean, lots of work coming in here. But another question by Dr. Joshi is, I think it's a general question. Anybody can answer. What do you do for an acute talus? I don't know whether he asked for about a talus extrusion or a type 3 talus when it's lying outside. How would you address the sort of talus which is lying outside the body? Anybody wants to take that?
Sir, so the type 3s are most commonly posteromedial extrusions. The most common way that the body would go out is posteromedially. And you have the neurovascular bundle lying there. The fragment is lying directly under the skin. So closed reduction, although you can try, but practically I have never been able to reduce it closed. So if it fails, you have to go in and reduce that body, because then you are asking for trouble if that body lies unreduced for a long time.
So is it a question? Is it an open extruded talus one? Is the question, or?
You see, most of the people don't understand. I've seen my residents talk about a type 3 which is lying outside as an extrusion of the talus. So that's a totally different concept. A total talus extrusion is different from a type 3 with the skin break. They are mostly inside out injuries. So that's an issue. So anyway, I think Siddharth has answered that. But taking it forward, one of the comments which was made and which is grossly misunderstood now is that you do not need to, they say don't have to address the talus immediately within 24 hours to minimize the chance of avascular necrosis. I tend to say that this statement is misquoted. What this was done by Heather Vallier's paper. They said you've got to reduce the type 2 and 3 by closed methods. The surgery to fix the talus can be done later. That's the difference. So many people think that I can leave even a type 2 or a type 3 subluxated or dislocated outside. That is incorrect. You have to intervene. If you cannot reduce the body of the talus immediately, you will have to take them to the OR to do an immediate reduction to minimize vascular insult. If you don't do that, then you're going to have problems. So that's an interpretation which needs to be done. Any other questions anybody has? I think Dr. Rana had one. Balwinder, do you have a question?
Yeah, so just taking the dislocated body with a fracture of the neck part a little further. So as Siddharth pointed out that it is extremely difficult. The literature recommends close reduction of the dislocated part of the talus into the mortise and then delayed reconstruction for the fracture of the neck. But it is difficult for a large extruded posterior medial body fragment to be reduced closed. And you end up opening it up. So what would be advice of Siddharth and Tim both? What approach would you take in these situations? And would you not end up fixing the entire injury at that setting? And how would you proceed with the skin closure at that point in time?
Vinder, I'll take it a little more because I think I work closely with Siddharth on this. The issue is what I used to experiment in the 90s was I used to put a Steinman pin in the body as a closed thing. And the different scenario, if there is a medial malleolus fracture and if there isn't a medial malleolus fracture. If there is an associated medial malleolus fracture, it becomes relatively more unstable. Therefore, if you distract the calcaneus, the chances of putting it back there are there. But if I have taken the patient into the OR in the evening or night or something, and I am taking this patient under anesthesia, I would fix it definitively at the same time. The concept of trying to do a close reduction is meant in the ER where, and let me very honestly, anybody who's not trained in foot and ankle techniques will not be able to reduce a type 3 talus fracture. So this is all in theory, that if you can reduce them in the ER and put in a plaster, slab, etc., wait for the experienced team to come in and do something next day. But if the experienced team is already there, they should not waste the time and they should fix it definitively at the same time. What do you say, Siddharth, on this?
Absolutely, sir. I hate it when a type 3 comes in the middle of the night because I know I have to go to the OT and OR and do the case. The resident can't do it. And if you are in there, you might as well fix it.
That's the advantage of being a professor. I don't have to go in the middle of the night. Siddharth will go for Mckee.
So you lost your. Yeah.
I'll just show you. We are out of time, but I think the one complication which every general orthopedic surgeon fears is avascular necrosis. So I think we should discuss one case for about 5 minutes about avascular necrosis. And I'm going to share my screen and I'm going to ask all the learned participants here to tell me what they're going to do about here. So I'm going to ask the questions. Okay, so we will just take 2 or 3 minutes about managing avascular. Can you see my screen, guys?
Yes.
Okay, so what we will do, 1 second. Yeah, that's right. So I'm not going to go into the incidence, but it increases with increased displacement. I'm going to ask the simple question of this patient, type 3 fracture, which I did in type 210, 220, about 10 years ago. This patient had a comminuted medial malleolus fracture at the same time, and it was a type 3 fracture. We reduced it, we fixed it, we did an OREF, and you can see that the talus body is white. What should we do? Who's going to take the first call? Tim? Balvinder?
Yes.
Yeah.
So 3 months down the line, with a reasonably good reduction of the talus neck, and I would just protect it from weight bearing for a longest period of time, maybe about a few more months, and expect that the talus body does not collapse, and it does, with the fracture well fixed, give it time to revascularize and solidify, and then delay the weight bearing and wait it out rather than doing any intervention at this stage. If it does not collapses, we can still have a very good result, because avascular necrosis does not always equal to collapse. And even if it collapses a bit, patients do reasonably well. So I would not do it anything at 3 months and just see a follow-up of the next few months after non-weight bearing.
What would you do in Edinburgh, Tim?
Yes, I would agree. I think the chances of it becoming fully revascularized are low, but it's such a beautiful anatomical shape that even if it will undergo some partial revascularization and become functional, if not perfect, then it would be better than embarking on complex surgery at this point. So I would agree. I would give that another 3 months before considering operating on it.
And what would you do in the 3 months? Anybody?
He would have a removable orthosis.
Or with an orthosis. Okay. One question. I mean, I do not know. I'll float it to Ken in the US. What do you do? Do you actually take cognizance of the fact of the extent of avascular necrosis in the weight-bearing area? If the avascular necrosis is in the whole bone, or if half the bone is involved, like in Perthes, we talk about the intact lateral pillar, etc. Does that have a role in the eventual collapse of this?
So can I answer that?
Yeah, please.
So that's what I think, reading through the whole Ramalt and Zwitt's paper, that's what they talk about, less than 1/3 and more than 1/3 of the AVN, where less than 1/3 of AVN, they almost treat it as a normal talus. And if there is malunited or non-union, then they would treat it accordingly.
So 1/3 is this length.
Yes, yes.
So you have to have the weight-bearing pillar intact, and then you can treat it. If it is like this, the whole involved, then you have problems over here.
Correct. And also at the same time, just adding to what Tim and Balwinder has said, I don't know, but going through the hip literature, we would give them bisphosphonates as well. Do you think have a role on that? IV bisphosphonate and oral bisphosphonates?
I am not aware of any literature which supports use of alendronate in avascular necrosis of the talus body.
No, so that's what. So not in the talus, but there is a significant literature for femoral head. That's why.
But that's is idiopathic avascular necrosis. These are post-traumatic. And if you've got a good reduction and the vascularization starts, that's a different kettle of fish compared to the idiopathic guys. Anyway, let's just see what we did for this patient. So the options over here was we gave them a protected weight bearing. We gave them protected weight bearing in this orthosis. And over time, this patient resolved to become totally round without any collapse. So the message here is that, if you, as Tim says and Balwinder says, if you bide your time, you give them protected weight bearing, there's a great chance that these will resolve. You don't have to be so scared of AVN as if it's the end of the world. That's what I'm trying to give. And this is the patient who has good function afterwards. So anyway, this is another fracture which was fixed. I don't know how they fixed it in Goa, one screw from the front and one screw from the back. But anyway, he came with avascular necrosis. Same thing we did to this patient. He was allowed to walk bearing. You remember, if you do an offloading orthosis, patellar tendon brace, you have to also elevate the opposite foot. You have to put in a heel on the opposite foot. Otherwise, they walk very, very badly. And again, over time, these guys revascularize. Okay, so, but this is the take-home message. AVN is not the worst complication we can see. If the fracture heals, chances of AVN healing are good. You need to avoid weight bearing. You could do MRIs. It will help you define the extent of involvement, but AP X-rays of the ankle are also equally good. So if you got, as Pradeep said, Ramalt has said 1/3. I believe that if less than 1/3 of the talus body is involved, the chances of collapse are very low. And it's the accuracy of reduction and stability of fixation, which are prerequisites for these patients to heal well. I won't go into this AVN with collapse because I think we've run out of time, and we'll go on to the next session. I'm going to stop sharing my screen. So in the next lot, we're going to start with Balwinder. Balwinder, are you ready for the calcaneus?
Yes, sir.
Okay, we'll go with Balwinder because we are already 6 minutes behind time, but we'll quickly go with Balwinder to start his talk.
Yeah. Thank you very much, sir, for giving me the opportunity, and thank you, both organizers. So this is about open reduction and tunnel fixation of a displaced intra-articular calcaneal fracture, and I believe I was told that the mandate was to show the surgical video, so I'm just concentrating on the surgical steps. But just to take you there, the basic principles have to be borne in mind. Have to be borne in mind. The fracture and its fragments and deformities need to be defined very clearly before embarking upon any kind of reduction of the calcaneal fractures, for which a CT scan is obviously absolutely essential. And we must understand the mechanism of deformities and the various problems that an axial loading fracture like a calcaneus has. So there's a primary fracture lines which then displaces because of the body weight on the tuberosity, and on the top the talus, displacing the primary fracture line with the tuberosity going into a varus and leading to a loss of height as well as a varus displacement and a widening of the heel with the blowout of the lateral wall. So that heel is wide on that part. So all of these deformities have to be addressed in a surgery for the calcaneus fracture. If we are doing an extended approach or we are doing a sinus tarsi approach, the steps of surgery are almost the same, and all of the problems associated with the calcaneal fractures with the loss of calcaneus height, widening of the heel, impaction and rotation of the subtalar facet, the deformity of the tuberosity, and the various fracture fragments in the anterior process, they all have to be addressed. So I'll be discussing only the basic fracture by an open reduction and internal fixation by an extended lateral approach. We have to be aware of the various intraoperative imaging modalities. That's again a basic principle that we all should know, how to take an axial view and how to take a Broaden's view. So that is my OT technician, just for the purpose of demonstration. With the lateral position, the C-arm is placed on the side of the surgery obliquely and then rotated. Then that's the way you take an axial view along with the Broaden's and the lateral views. So we must be aware of the circulation of the lateral calcaneal skin. It's important. If we place an incision like this or an incision like this, then we are bound to have skin problems in this particular area. And because we know that there is an artery, which is a branch of the peroneal artery, the lateral calcaneal artery there, which comes from the peroneal artery and goes slightly posteriorly to reach the dorsal lateral side of the skin there, where it joins the plantar skin. So any incision which goes in this direction might peril the lateral calcaneal artery and is the cause of necrosis of the tip of the flap. So the incision should be placed a bit posteriorly, we know now, towards the tendoachilles, so that the artery as well as the sural nerve, which is there in this location, comes up with the flap dissection and is not injured by our incision. So here is a case. Now, Dr. Egol in the next talk might say, hey, all of these cases can be done by sinus tarsi approach, and I would be hiding here and there. Possibly that's true. But for the purpose of learning, possibly it is important to know the steps and which are learned better by an extended lateral approach in the initial phase. So here is a case where we have a depressed facet, a joint depression type of a fracture there. You can see all of these scans in the sagittal plane, in the coronal plane, have to be studied properly to decide what are the fragments and where are they lying. The incision is, the vertical part of the incision is closer to the tendoachilles, almost exposing the Achilles, and it has to go all the way directly down and not angled or curved in this way to protect this area of the flap, because that is where the artery is coming like this. And then it has to be curved in a gentle curve and follow the glabrous, the junction of the glabrous as well as the dorsal skin, the plantar and the dorsal skin on that side. And along that junction, the incision has to be placed meticulously. The dissection starts at the curve of the flap, and it is a full thickness flap without any rough handling of the tip of the flap especially. So typically advised to use back of the forceps to lift up the flap, and every time your knife goes in, it should touch the bone and not enter the flap. So a full thickness flap is raised from the lateral side, and the next step would be then, once the flap is reached the peroneal tendons, lift up the peroneal tendons subperiosteally from the lateral surface, and then we place 2 or 3 K-wires to keep the flap atraumatically retracted. The first of them is on the anterior side in the cuboid, and that almost tenses up the peroneal tendons. The second one is in the neck of the talus anterior to the fibula. The third can be on the backside of the fibula or on the backside of the talus tail. And these 3 wires atraumatically lift up the flap during the process of surgery. The second step is the defining of the lateral wall blowout, and this is the lateral wall blowout there, which has been lifted off here to show the depressed facet inside the calcaneus body itself. Once that has been done, then the next step would be to get the alignment of the tuberosity correct. Now, this is not the same case. This is a different case, but the same steps which are followed in all of these cases. The tuberosity is in varus. There's a medial displacement of the wall there, and we can see the fracture there at the subtalar joint. So this tuberosity, as the start of the fixation, a reduction in fixation has to be first aligned with an axial smooth Steinmann pin, a large Steinmann pin, and that Steinmann pin, once it reaches the fracture site, has to be pulled up to reduce the medial wall. And once that has been done, this pin is held by an assistant while the surgeon puts another pin to fix the tuberosity in this reduced position and fix it with the sustentacular fragment. So here is an example of that. This is a sinus tarsi approach. I'm sorry, this is not an extensile lateral approach. So you can see the assistant is holding the first pin, which was placed like this, holding it up, maintaining the reduction, and the surgeon then puts in a second pin in the direction of the sustentaculum talus. Because you invariably end up, the first pin is not in the right direction because you do not know many times what direction this pin is going to take. So it is wiser not to try and advance the first pin and just hold it in position and then put a second pin when you are wiser about once the reduction has been achieved. Once the reduction has been achieved of the tuberosity from varus and valgus, and many times it has to be pulled down from a position of, it has to be pulled inferiorly also. Then we come back to the lateral side, we see the depressed fragment, we lift it up and then reduce it from the lateral and taking guide onto the lateral surface of the inferior talus. The subtalar facet thus reduced, we fix it provisionally with a K-wire from lateral to medial, targeting the sustentacular fragment there. And then with the axial images, we identify that the wire is in the correct place, the tuberosity has been reduced, and the subtalar joint is seen there. Then we can fix the sustentacular, the lateral facet with a screw, which we have done in this case. This is a screw head. That is again an axial view. A screw has replaced the wire, and then finally we put a plate on top of it after putting back the lateral wall fragments and reducing the anterior process fragments also. So there are a couple of sustentacular screws there and a plate on top after putting back the lateral wall fragments, or the lateral wall fragments can be used to fill in the void in the body of the calcaneus, which has been lifted because of the depressed fragment was lifted up. So this is the axial view. And a good reduction of the facet has been achieved with 2 screws. Now again, the closure has to be meticulous. Most of the times we prefer to use a drain in calcaneal ORIF, and Elgover Donati stitch is to be used where all the suture knots on the outer side, nothing is on the inside. The flap side is free of suture materials. That's important to have a meticulous closure there. Now quickly I'll show you a video of the same steps. This is a double density time, a Sanders 2 fracture, not a very bad injury, could have been managed easily by a sinus tarsi approach, but for the purpose of demonstration, that is a fracture, the lateral facet depressed into the joint, into the calcaneus, and the calcaneus was in varus. So the wrinkle sign is there. We know it's been about 10 days since injury. The screen has shriveled. The same incision that we saw in the previous case, the vertical part of the incision is closer to the tendo-Achilles, and the transverse part of the incision is connected to the vertical part at the junction of the glabrous and the dorsal skin of the lateral calcaneus. So the dissection is started at the curve, full thickness dissection, and taking the peroneal tendons. Once you reach there with a retractor, and then we put in our K wires for that's a peroneal tendon there, and we retract the tendons and put our K wires under the tendon. Anterior wire has been put into the cuboid. The second wire is being placed into the neck of the talus, and the third wire into the backside of the calcaneus to retract the flap properly. Then we go on to the lateral side and dissect the lateral wall brow. We can see, once we invert the tuberosity of the calcaneus, we can see the sustentacular fragment or the constant fragment on which we will build our reduction, first of the tuberosity and then of the lateral facet fragment. So we dissect out the lateral wall fragment and remove it to fully visualize the extent of the lateral facet which has been depressed into the calcaneus, and that is where we see it. Once we have removed the lateral facet, we see the depressed joint there, and we can see the step. Again, the step first will be to reduce the tuberosity with an axial K-wire and taking axial images to see that the calcaneus has been brought down and brought out of the varus, and we have fixed it with the sustendicular fragment. You can also fix it with the anterior process at this stage if we think that is necessary. Next step is to lift off that facet which has been lifted up and aligned with the lateral inferior the lateral sustendicular fragment, and then provisional fixation with K-wires, and then a screw fixation out of the plate to fix the lateral depressed fragment with the medial sustendicular fragment there. Once that is done, then we put our plate and we take Broaden's view, the axial views, to see the correct position of the sustendicular screw, that it is exactly where it should be inside the sustendicular fragment and not inferiorly where the FHL in the neurovascular bundle will be. And then finally the plate, putting a plate on top of the calcaneus is not a challenge. The challenge is to reduce the fragments and the fracture properly. So this is a locking plate which is easily moldable, and obviously we do a meticulous Algova Donati stitch where all the knots on the outer side, and the inside we only take the subcutaneous tissues off the flap, and we mobilize them fairly quickly. This is at 2 weeks post-op. And before that, even before that, once the patient is completely pain-free, we start mobilization, ask the patient to do dorsiflexion, plantarflexion, inversion, and eversion. And we don't apply any splints immediate post-op also, just keep them on a heavy bandage. And then as soon as they are pain relieved, we reduce the size of the bandage and ask them to mobilize quickly. So that's, thank you. And if you are still awake, this is the time to wake up before your next talk again comes up. Thank you very much.
Thank you, Dr. Balwinder. That was a great talk. And we'll take questions to the approaches after we finish with Dr. Egol's talk on the sinus tarsi. Dr. Egol, would you be kind enough to share your screen, please?
Can you see that?
Yes, we can. Thank you.
All right. I also checked the video to make sure it worked, and it worked on my computer. So hopefully we'll go. I just want to, before I start, I wanted to respond to something Tim said before about the Lagge-Hansen classification. Everybody should remember that when Lagge-Hansen described that, he took cadaver limbs and put them in a vise and then basically twisted the ankle to create the fractures. And that will never, that's not the way it happens in real life. So when people break their ankle, it isn't like someone's taking their ankle and twisting it externally. Their foot gets planted in one position and their body internally rotates around, causing a relative external rotation of the foot to the body. So that study from Boston at the OTA, it should never be the same as the classification. It should be the opposite on every case. Anyway.
I'll take it forward one more bit. There is also, it doesn't take into consideration how much forward or backward you are leaning when the body twists, and whether there is an element of vertically directed force, and whether the foot is in equinus or plantar flexion. So there's much more to it then, and we can talk about it all day long.
Anyway, so I'm going to just build upon what was spoken about and talk about the sinus tarsi approach again. So when we think about all these foot injuries, I was always taught there's only 4 things the foot has to do. It has to fit in a shoe, be plantigrade, be painless, and be sensate. And if you can accomplish all those goals, the patient's going to be pretty good. So with calcaneus fractures, obviously there's a significant joint disruption, but there are other problems that happen. The heel gets widened, there's malalignment, there's perineal impingement potentially. Decreased heel height leads to talar impingement via the horizontal talus. So it's not just the broken bone and everything associated with that, it's the late effects of the malunion that we worry about. So we always want to restore calcaneal height, weight, width, and length. And we want to try to reduce that posterior facet as best we can to minimize subtalar arthrosis. But there is more than just the posterior facet. There's a middle and an anterior facet as well that have articular cartilage. So damage to those areas or damage to the calcaneocuboid joint also needs to be addressed at the time that we do these things. And this is what we just went through. This is the classic extensile ZWIP approach based on the flap of the lateral calcaneal artery. And we all know that there's a whole bunch of problems that can happen. And again, with plastic surgeons, we're able to manage a lot of these problems, but we want to try to avoid them. But sometimes we can't. And it's all of these soft tissue problems that really led us to to look at other ways of fixing this. And people have described percutaneous reductions and minimally invasive fixation for these, and none of them have been really very good until now. And this was, this obviously is a minimally invasive technique, the Essex Lopresti, and it works when you have a big posterior facet that's attached to the calcaneal tuberosity, right? Because you can put something in that fragment and bring it down and reduce the joint and percutaneously fix it, as shown here in the AO manual. But not every fracture pattern fits this mold, and we can't always apply this procedure to every type of fracture to gain the goals that we've set out for ourselves. This is what it looks like when this is successful. So the rationale for a sinus tarsi approach is to minimize soft tissue dissection while allowing for fracture visualization and reduction. There are some risks involved. Obviously, the perineal tendons are within the field. We have to be careful. However, it does allow, if you're unsuccessful in a good outcome from the reduction and fixation, you can always perform a secondary subtalar arthrodesis through the same approach. However, this is not an extensile approach. It's really good for when you have simpler patterns and only need to address the posterior facet. You can also extend it and get the anterior facet and address calcaneocuboid issues as well. But some of the other things that we need to do can be difficult, although they can be done, such as reducing the primary fracture line. And it's, as I mentioned, it's very good for simple patterns like this with a simple joint split and lateral wall blowout. Again, very small incision working right in the area, and with specialized plates that are designed for this approach, you can get fixation proximal and distal to the fracture to neutralize the reduction. So here's a video, and I hope it works. One of the reasons it may not work is because I did some editing before I embedded it. Hopefully it'll work. So again, here's a case of a joint depression type fracture with some extension to the calcaneocuboid joint. And you see the CT scan. There's some inferior comminution. I think indications include Sanders type 2s and 3s and some tongue type intraarticular calcaneal fractures that are more than just the simple, entire joint on the fracture fragment. Some of the benefits are a quicker time to surgery. In fact, you want to do this pretty quickly. You don't want to wait. You want to get it done soon when you can mobilize the fracture. And there is less incidence and risk of wound complication. This is the patient being set up in a lateral position. It can be done prone with the foot externally rotated as well. Landmarks are the tip of the fibula and the fourth metatarsal. So an incision will be made through the skin and subcutaneous tissue in line there, right? And you will have the perineal tendons inferior to that line. Oh, here we go again. And the EDB muscle belly superior to that incision line. So, I always use a tourniquet. We inflate to 250 millimeters of mercury, and we leave it on for no longer than 2 hours. So the incision's carried down. You got to be careful, of your sural nerve branches, finding the perineal tendons there and sharply dissecting between the perineals and the EDB above it will give you an approach right into the sinus tarsi. Now this can be carried down distally. Again, the perineals are going to dive plantar and towards the base of the fifth metatarsal. But again, here you can see elevating up and elevating back. You have to retract these tendons. Oftentimes you will use small Homan retractors, and they're under a lot of tension. And you just got to be careful that you don't get it with the knife. You're not going to avulse the perineals by retracting. You can see here that you get a view into the subtalar joint, removing some fat and some soft tissue. And again, visualization is key here. Here, this is a K-wire that's going up into the talus to act as a retractor. Then we try to reduce the primary fracture line and put a K-wire from the heel across into the sustentaculum just to hold that reduced. Again, some people will put a joystick to manipulate the tuberosity fragment if it's not well aligned. You can then book open your fracture, hold it reduced, and then a simple lag screw will go across the posterior facet fragment. Now you can see that the lateral wall blowout is basically manipulated to allow for the this specialized plate to be placed, and you can kind of manipulate it to fit underneath the perineal tendons, and you might need a little bit more excursion posteriorly along the tuberosity. But following that, you can just bridge the fracture. This is again as a locking plate. You don't have to utilize all the locking options here. But I find if I'm using a small little plate like this, I tend to do it because this is not the best quality bone where you're going to be putting the screws. The best quality bone is obviously under the posterior facet. Again, we've added a couple of larger screw wires for 6.5 cannulated screws to go across the primary fracture line. And those will be over drilled with the screws once we have the joint reduced. So you can see the rest of the screws are placed, and we're checking under image now. Once we are happy with the way the joint looks, and we have our provisional reduction held prior to this, then we can put the cannulated screws over these wires. Which will add strength to the construct. And here you see the image of what we're trying to achieve. The wires can then be removed. The K-wire is removed. You see the Harris view shows restoration of the normal heel alignment. Wound could be then irrigated. Some people will repair the interval between the EDB and the perineal sheath. You can do that if you can. I tend to just go straight to skin with nylon in a simple fashion, tension-free, tourniquets let down, and everyone gets a DVT prophylaxis. We start early range of motion, and we keep people non-weight bearing for 10 weeks and then advance them to weight bearing as tolerated. I splint people for 2 weeks to allow the wound to heal and then transition them to a post-op boot, which is really for protection. They don't have to sleep in it, and they can move their foot as much as they want, but it prevents them from being stepped on or any unfortunate accidents. So here's what they look like, early follow-up. And at 6 months, the patient did very, very well. And certainly, obviously this is not as severe a fracture as some of the ones that we do see. So we would expect a reasonably good result. So with that, I will end the video and take any questions that you may have.
Okay, thank you, Ken. Well, has the faculty got any questions? Because we'll have to look at the ones which have come in the chat group after I've shared my screen, and we'll have to see how we go about that. Okay. Ken, you'll have to stop sharing your screen first.
Now I'm doing that right now. I apologize. There we go.
Thank you very much. Does the faculty have any questions to
Kenneth, can I ask a question?
Yeah, please.
So, what is the learning curve for these kind of for the sinus tarsa approach, and any wound complications?
Well, there's a learning curve to everything, right? But I think if you're familiar with the anatomy, just like anything else, and the principles, you get it pretty quickly. I think obviously the more complex, 3s and 4s are certainly less likely to be able to achieve an adequate reduction. This is for the simple 3s and the 2s, really, in my hands. As far as wound problems, I haven't seen a single wound problem with this approach. Now, just because I said that, the next time I do it, I'll have a problem. But I would say I have probably about 15% of my extensile approach, I have some kind of wound problem, superficial epidermolysis, drainage. I follow all of the, closure protocols, 2-layer incision, Algar Donates, all that kind of stuff, immobilized. And, it's a vascular insult. And you'll know for the extensile approach, if you let down the tourniquet and watch the skin pink up afterwards, for those people, you'll see little white spots sometimes. Those are the people who are going to have a wound problem. You can predict it. You see it right after the surgery. So that's what I started doing when I have to do that. And I know who I have to watch a little closer.
Okay.
Regarding the reduction, I think if you've done a few extensile approaches and you are able to, reduce them, then doing this indirect method through the sinus tarsi or even percutaneous becomes fairly easy. As Bilwinder said, you've got to get the heel out of varus and you've got the medial wall reduced first, and then things fall into place.
Yeah. I think the nice thing about this is you do it acutely. You do it in the first 3 or 4 days, and the fracture is still mobile. The hardest thing about waiting 2 or 3 weeks to do a calc, an extensile approach, is that it's already healed and short, and then by the time you stretch things out to their anatomic length, then it's hard to close the wound again.
Yeah.
So it's easier.
You have a comment, Balwinder?
Sir, yeah, so this is not to favor the extensile approach over the sinus tarsi, but some of us do believe that the complications of extensile approach have been overplayed in the literature. And we have seen, although Dr. Kenneth has a huge experience, I believe, in doing sinus tarsi early on, but there are complications of the sinus tarsi approach. And we have seen skin problems. We've seen some of sural nerve more commonly injured with the sinus tarsi approach. And sometimes I believe that these cannot be done as early as people claim. In a calcaneal fracture, if you do try an early on sinus tarsi approach, also has its own set of soft tissue complications. And if you know the vascular anatomy on the lateral side of the skin of the calcaneus, and we place our incision meticulously, and we allow a significant amount of time for the skin to settle down before we go in for surgery, the complication rates are not that high.
Okay, that's fair enough. So I'm going to share my screen and talk about something different. I'm going to be talking about fractures of the interior end of the calcaneus, because we call them fractures of the calcaneus, but do we really understand them? And let's see what I'm wanting to talk about. You see, when you get injuries of the interior end of the calcaneus, you could get an isolated inversion injury, which causes a fracture, or they could be part of the displaced intra-articular fractures of the calcaneum. And this little isolated injury is actually sometimes missed. And people often see them with the persistent pain later on with MRI changing, etc. But this is not what I'm talking about today. I'm going to be talking about a different kettle of fish. The second type of fracture is the anterior end of the fracture when there is a large anterolateral fragment. We see them all the time when we address the intra-articular fractures. Even the case where Dr. Kenneth had shown there was a separate screw put in for near the calcaneocubar joint, which talks about the fact that this fragment probably needs to be put back in. So that means that the primary fracture line actually splits the posterior facet and then goes forwards, involving the calcaneocubar joint and the anterior process of the calcaneus. But unfortunately, I'm not even going to be talking about this fragment today. What I'm going to be talking about are anterior end of the calcaneus injuries caused by a third mechanism. And this is still a calcaneus fracture, but it is a different kettle of fish. Now, I'm talking about injuries caused by abduction or a direct impact injury, where there is significant lateral column involvement and subluxation of the joints, etc., which we see over here. Now, when you get an injury like this, which is involving the interior end of the calcaneus, it could be the only injury. Like in this particular case, there's a fragment there, there's a fragment there, but the rest of the bony architecture of the hind foot is okay. Or it could also be part of a more complex injury, which in my experience is much more common. Because like in this 47-year school teacher, female, she was involved in a road accident. She got a comminuted fracture of the interior end of the calcaneus. And if you can see, there is involvement of the calcaneocubar joint significantly. the subtalar joint is not in place, and that has led to the fact that there is a subluxation of the talonavicular joint. So this is a complex midfoot, hindfoot injury. So here, as Siddharth is doing in our institute, you first reduce and stabilize the subtalar joint, and then once the talonavicular and subtalar joints are reduced, you address the lateral column injury. In this particular case, if you notice, there is a bone gap which needs to be filled up. And that we did by using a distractor. This is an indigenous distractor. In India, Tim and Ken, we call it a Jess fixator, which is a cheap fixator, which distracts it out, allows us to reduce the calcaneocuboid joint, and then insert large pieces of tricortical graft over there. That's what we did. We inserted a tricortical graft, and because this was an open injury, we did an external fixator, continued the same thing for 6 weeks, and allowed full weight bearing at the end of 12 weeks when everything had healed. And this is what the healed fracture looks like. There's a decent subtalar joint, there's a good calcaneocuboid joint, and the bone graft is getting incorporated over here. And that's what is happening at 4 years follow-up. I have a 9-year follow-up of this patient now, and she's doing fairly well. She's a teacher in the school, and she's gone back to, she's carrying her bag there with her. Okay. So that's what I'm talking about, that if you reconstitute the length, the lateral column length, and get the subtalar joint right, these fractures do well. Now, another fracture, which is also had an open, many of these guys come with lacerations or wounds over there, which need debridement. Plus, you need to be ready to use a fixator along with multiple K wires to be able to reduce it. So you can see here a similar injury pattern with the fracture over there and a large loss of the soft tissue, which even the X-ray is showing. And again, we did the same thing. Now here, what we tried to do is we tried to sort of cross the K-wires to aid the distraction. And that's what happens over time. The fixator comes off, and over time, even the wires come out, and these guys do fairly well if you've maintained the length and kept the length to the right position. Now, these are different. They are not injuries due to the talus pushing down into the calcaneus. They are forced abduction injuries. And the first case was reported by Hunt when in a professional motorcycle biker who was fixed with K-wires. So what really happens is, instead of the cuboid fracturing, then the nutcracker mechanism, that means the foot goes laterally, crushes the cuboid, the injury force is more proximal, and the compression happens at the anterior part of the calcaneus. So that's what happens over here. And ideally, which we also recommend today, if you have a closed fracture, the lateral column length should be maintained by a plate. The examples I've shown you is, one, they were early days of my learning. And secondly, there were open wounds over here where we were apprehensive about putting, plates with only skin covering this and maybe a part of the extensor digitorum. So, but the ideal scenario is we put in a plate like we would for a comminuted cuboid fracture, and that's what happens. Now, this is another case which I'm going to show, and probably my last case, because this is a case which, no, this is not the last case. This is, we were able to reduce it well. You can see we've got the calcaneocuboid joint in place. Again, fixed it over there. Again, we are very liberal in using our distractors and an external fixator. This was the case of polytrauma. If I remember, there was an associated tibial fracture and an acetabular fracture, but they end up doing well. But remember, if you do not do a good reduction and a good stabilization, even initial good reductions give late complications. Now, this is a complex midfoot trauma. But if you look at it, the fracture primarily, forget about the dislocations. The navicular is dislocated medially. The whole forefoot has gone laterally. But the complex fracture is in the interior part of the calcaneus. So the interior part of the calcaneus has borne the brunt of the injury. And this came to us 8 days after injury. There was a lacerated, contaminated view on the medial side, extending into the plantar aspect of the foot. The skin condition was poor and there was slough, and this patient was controlled diabetic. You can see small amounts of blisters forming over there also. So the CT scan also shows the same thing. There is some combination of the navicular over there, but most of the issues are in the interior part of the calcaneus, along with an unstable midfoot. So this foot was debrided, and at that time you could see that the whole of the midfoot is dislocated. But as I say in all my talks and all my teaching, whenever you reconstruct the foot, you have to build it like a house. You built it from the bottom up, from proximal to distal, and that's exactly what was done. First, the navicular was reduced onto the thallus. It was fixed there. Then the rest of the forefoot was reduced onto the navicular. It was then stabilized. Both the medial cuneiform and the medial column were stabilized. And then you see what you have got on the lateral side. And now you distract the lateral column to try and get out the length. Because as Tim White also showed us, this bicolumnar concept, unless you get the columns right, we are going to get into trouble. And that's what we did. We opened it up, you try and put back the calcaneocuboid joint, and then you fix it with an external fixator. You can see there is an obvious soft tissue loss over here. So a plate would have been ideal, but we were a little apprehensive. We still are scared of putting plates in these neglected open injuries, and therefore we used a bicolumnar external fixator. This wound needed a flap, and this flap was done, a free flap was done, and then the patient went home with a plan to come back for grafting and fixation, definitive internal fixation, but it didn't come for 5 months. He said he's going to get treatment in a regional hospital, and then we requested him to come back and see us after 5 months, and he comes with this X-ray at 7 months. There is an abduction deformity. The navicular became avascular and collapsed, and the anterior end of the calcaneus actually caved in. But if you look at the lateral view, the foot is flatter, but it is straight. And surprisingly, he had a fair function. So he was not too bad, because even when he was walking, he was doing fine. And this guy says, I'm a farmer. Don't have the time or the money to go in for a second surgery. And he's fairly satisfied. I, as a surgeon, am not. Because when I look at that foot, I am horrified. But this guy says, I'm okay, and let's see how much he lasts. It's been 2 years down the line, along the line. So the take-home message about the fractures of the interior end of the calcaneus is, we need to understand the injury mechanism. It's a totally different fracture, folks. Whether it's an inversion injury or whether it is a midfoot injury, except for the one where the displaced intra-articular fracture splits the anterior part, these other injuries are different fractures. They are more of midfoot trauma, they are more of fracture dislocations, and the stability methods are different. The joints involved are different. So the management is by articular reconstruction and column length restoration. And the results are disappointing if the overall injury pattern is not understood. And if you don't understand this in the first place, you're going to end up with residual abnormal gait pattern and pains for many years. Thank you for your time. I have now stopped screen sharing, and we are open for questions, guys, and we can, if there's time, we'll go and take a case of a malunion. Any questions or any comments? Can you hear me, folks?
Yes, sir, we can hear you.
Any comments or questions while I open the chat room to see?
Yeah, the interior process, you have amazing type and difficulties of cases at your center being a referral center. It's a very, very difficult situation. So anterior end process shattered calcaneus can be extremely difficult to get back in the correct alignment, and the articular surface may still remain damaged. So have you had any experience with doing primary fusions in non-reconstructible anterior calcaneus?
Well, most of the guys who come to us are parts of complex midfoot injuries. So we also have medial side instability. So we try and get the length out. And we've also had, if you look at the joint surface per se, the calcaneocuboid joint is not so often crushed. You are able to take the cuboid as a template and put the anterior part of the calcaneus back there. So if we can get the length with a bit of tricortical bone graft and stabilize the medial side, then the only movement at the joint required is a bit of a glide. Calcaneocuboid joint requirement of movement is very limited. It actually takes part in the weight bearing. So if there is even a fibrous kind of a involvement of this joint, we haven't had too much pain over here. But what I have said is that if the calcaneus fracture itself doesn't heal, the foot tends to collapse. And I have not seen it in one, I've seen it in 2 or 3 cases, because anyway the medial column, if it doesn't have a fracture, has to heal by soft tissue healing. The dislocation has to heal, and that is unstable in the first place. So if the calcaneus fracture doesn't heal, doesn't contribute to the length, then there is an instability. And this is where Balwinder's question comes into importance. If we are thinking that instability of the lateral column is going to contribute to medial instability, there may be a point of view about fusing the calcaneocuboid joint in the first place. I see Pradeep wanting to ask a question.
So I'm just going through your cases only. Now, if you're not plating, and most of the cases which you have shown, you're not plating those lateral side, you're probably putting K-wires and putting an external fixator, the Jess fixator. So if you were to get, if you think about the same ring concept, the medial side, the soft tissue you want to heal. So on the lateral side, you would want to keep the fixator as long as possible. How long are you planning? Are you keeping those fixators? Is it 3 months or 6 weeks or even more?
We keep them for about 6 to 8 weeks. But if you notice the K-wires, we try and put the K-wires almost as a cross perpendicular to one another. The only reason which I said why we haven't plated the cases I have shown, 1 or 2 of them were in my early days. I mean, when we were doing all these fractures and understanding them was in the early 2000, 2005, 10, etc. Now, if it comes to me and there is no bad wound, there is no doubt it would be plated. That is a given. The message I would like to do is do a primary plating. Even if there is a comminuted cuboid which is crushed with a midfoot injury, you would plate it. The same applies for the calcaneus. So the issue over here is, in our institute, 2 factors come into play. One is the cost. Second was originally ease of using plates on the lateral side. But we've overcome that now. Then if there is no wound, there is no doubt the lateral column should be plated. Any other comments or questions? Anybody? Okay. Then what I'll do is we'll end our talk by having a case of a calcaneus malunion, which we can discuss. I'll show the case and I'll share my screen. And we've got about, I think, 9 minutes left. And we'll take it further from there. So I'm going to put this case up and then we'll take...
I think we've got about 20 minutes left.
No, it's 10 to 9. We have to finish at 9.
Okay.
Okay. So this is a 40-year-old male. You see, 1 year post-trauma. There's heel height loss, there is significant varus, there is subtalar arthritis. And the patient has pain. He doesn't have rest pain, but he gets pain when he walks a short distance. Any takers from the faculty about who's going to be, discussing this case with me? We have Balwinder, who's doing a lot of calcaneus fractures. If Tim is around, Tim, what would be your comments? Or what would you do in Edinburgh first? Okay, Balwinder, maybe you got to take a call on this. Oh, Tim is here. Okay, Tim.
Tim is here.
What are your thoughts about a case, 40-year-old male? He's a farmer with the heel height loss. There's some varus and subtalar arthritis.
Yes, and I take it that the arthritis is the source of his pain. You've identified that clinically and perhaps with an injection to cure his pain.
Yeah.
Okay, so as usual, my approach would depend a little bit on the patient and his preferences, and would start off with the potential in a physiologically unwell patient with the possibility at least of some external orthosis. But otherwise, I think if he's in any way fit, this is going to have to be fused in order to give him a durable and predictable outcome. Now, my experience of these is of fusion with a bone block. And I've used allograft here rather than tricortical iliac crest, simply because of in order to avoid morbidity. And so I've taken, we have fairly easy access in my institution to femoral head allograft. And so I can take a triangle, a block triangle of that, open up the posterior aspect of that subtalar joint more than the anterior aspect in order to regain some heel height, and then fix that bone block with the prepared surfaces in exactly the same way as you've shown previously with cannulated screws from the heel heading up into the talar body.
Balwinder, your comments?
Yeah, I would agree to that. Yeah, this patient does need a distraction subtalar arthrodesis because there is a significant loss of heel height, and you can see the talus in the ankle mortise on the lateral view is actually dorsiflex. So the talar declination angle is not correct. So this needs to be corrected. This malunion is obviously affecting his ankle movement. Not only the subtalar arthritis is a cause of pain, but he will have some problem in the ankle movement also. So he needs a distraction subtalar arthrodesis, which achieves the calcaneus height as well as corrects the talus alignment into the mortise.
I think that's a very good point, Balwinder, and from from a large percentage of our listeners today are from the general orthopedic pool. So people forget the fact that the dorsiflexion, relative dorsiflexion of the talus, which happens because of this subsiding, is a source of pain over here. So that's the key point, that when you get the heel height back and you reconstruct this angle, this source talus will come into plantar flexion. Now, what about, we classified types of malunion into 1, 2, 3, etc. With so much collapse, don't you think that the lateral wall could be causing any problems? Would you need to address that in this scenario? Pradeep, would you like to talk about that?
So before going ahead, and I would like to have a bilateral Salzman view, the standing hindfoot axial view, just to check. One is, of course, how bad is the varus? And second is, as you rightly pointed out, the lateral wall. Now, lateral wall, how much he will have pain because of the impingement or because of the peroneal tendon irritation. Usually those patients are in valgus, not in varus. So varus patients, I don't think that lateral wall should be an issue, but I would definitely like to get either a hindfoot axial views or a CT scan and look at the coronal sections.
Okay, but I personally would like to tell you, most of my patients who are in varus also have a significant degree of lateral wall extrusion. I would suggest that the lateral wall extrusion is a sort of quantified by the extent of this thing being pushed down. That way it collapses and breaks it up. Anyway, since you got not too much time, that's what he is. So if you look at it, he is in some degree of varus. And there is also a significant lateral wall extrusion. So a simple distraction arthrodesis may not be enough. We will have to sort of take out the lateral wall. So since you're all saying distraction arthrodesis, what would be the steps of doing it? Anybody from the other faculty wants to address it? Would you do an extensile approach, a sinus tarsi, or as Siddharth has shown us, a posterior approach? Anybody else in the faculty wants to take it up? What would you like to do? Would you like to also take out this piece of bone?
Sir, may I?
Yeah, please, Siddharth.
So, sir, in addition to you already said this, but this person has a significant subfibular impingement and a difficult heel varus and a difficult distraction arthrodesis. So I would not venture to do a sinus tarsi in this case. I would choose the time-tested extensile lateral approach. And as the first thing, I would do an exhaustectomy of the lateral wall. That gives me a good space to play around with the joint. Then open up the joint and see if I can correct the varus. If I cannot correct it all at the subtalar joint, I may contemplate adding an osteotomy in addition to the distraction arthrodesis.
So that means you're classifying this as a type 3.
Yes, this is a type 3.
Yeah, where you could do a calcaneus osteotomy.
Yes.
But what do you mean by trying to correct it at the subtalar joint? Because my experience, I mean, over time is that if I'm putting in a graft, even using the lateral extensile approach, my graft tends to be placed laterally. It's very difficult for me to go that much medially to bring it out of varus. So maybe, this often becomes an issue. And those of you who've grown up with me, Siddharth is one of them, we try and push our graft medially to get it out of varus to some extent. But then if you can get the heel height and the exostosis out, then getting it out of varus that much may not be an issue. So it works many of the times. So let's see what was done. This was distraction fusion at 6 weeks. Again, if you notice, as Balwinder and Tim said very rightly, we use Elac-Crest grafts. We measure it out how much we want to do it, and if you notice, the talus has gone down and the screws have got up, and there's some extrusion of the graft at the back. Pradeep, you had to say something?
So just before going ahead with this, means why not do a posterior approach, where you could do a posterior approach, right? And access both on the medial side, lateral side. You could do an exhaustectomy as well and correct the varus as well. That would probably prevent it, or you don't need to have that extra calcaneum osteotomy to correct the varus. Just a thought.
No, I know, but what we are doing here, if you look at the AO manuals, they are talking only of the longitudinal limb of the extensile approach, the posterior lateral approach, which we published. Dr. Sharad in our institute calls it the open envelope approach, where you can open it up and even do an exostectomy and do everything. You don't need to go to the medial side. I mean, even if you have to do a varus correction, you can just take out a wedge from the lateral side, both by the extensile approach, more difficult by the posterior approach, and then correct it, and the screw will hold both of them. But we usually keep that for the worst of the worst cases, when we add a varus osteotomy at the same time, because that leaves you with two surfaces to unite. And if you got complications, you got double the amount of complications. So this is what was done in this case. Sorry to say this. We got this heals over time, heel height is maintained, and the patient gets a painful gait. So what have we learned from this case? What we've learned is, that's the other case. So what have we learned from this case? We have learned that, as Tim says, first identify in a calcaneus malunion where the pain is coming from. It's very, very important. You need to understand that the calcaneus has 6 surfaces, so the pain could be coming from anywhere. So if it's all on the subtalar joint and somewhat some pain from impingement on the lateral side, we can get away with exactly what we've done. But if there are issues other places, we have to understand. You could have a medial side pain, you could have an undersurface pain. So address the pain and the deformity together. Don't address the X-ray alone. So I'm going to show you another case, which is a bad case. So this is another case. Look at this. Now, Siddharth talked about something. Siddharth, I think you've seen this. I don't know whether you were with us when we did this case.
I have seen this case.
Yeah, this is the issue again. This is actually almost like not a full fracture dislocation, but the whole of the calcaneus has shifted into varus. It's migrated laterally, and the biggest issue the guy has is pain due to fibular impingement. So do the same principles apply as we did in the last case, or do we need to do something additional?
Yeah, I think the primary fracture seems to be showing a flimsy fusion. If at all there is
almost like a non-union calcaneus, which you've unheard of.
Yeah, it is almost like a non-union. So we'll have to address that along with the other problems that we had in the first case. That is the subfibular impingement, the lateral wall problems. There is a non-union, and then there is a varus, and then there is a loss of height with significant dorsiflexion of the ankle. So all of this is an extensile approach. And there is a calcaneocuboid joint problem also seems to be here. Not very clear on the X-ray, but I would like to see the CT to assess the anterior process, that is the CC joint, and decide which areas are actually causing pain. So apart from the lateral wall excision, the distraction arthrodesis, grafting of the non-union and fixation with screws into the subtalar joint, will decide about the CC joints. If it is painful, then may have to address that also at the same setting.
So this, you are right, in the CT scan shows that it's not united. The whole of it is under the fibula. And you know, the issue was when we went to approach it, we had a big problem because the fibula was being hidden. But the key point here is you have to do a distraction fusion. And I've included this case just to show you how much we can use these laminar spreaders to open up the joint and bring the heel back. And we have a trick of putting two K-wires perpendicular to one another, put them right across the joint so that, and this is the lateral wall which has been excised, where the finger is showing a huge amount of lateral wall has been excised. We put the K-wires across and then we put it in that position, and this guy also heals with a good joint. But you can notice, as Balwinder was saying, there were some problems with the fibrous ankylosis here, and there is some problem happening over here at about 2 years follow-up. We see what happens, but that's what you need to address when you have this calcaneus malunion. I'll have to say thank you guys, because we are now beyond the 9 p.m. deadline, and we will have to excuse me, I'll have to stop this phone because I am in a webinar. I'll have to tell them to stop. So, any questions, anybody, before we wind up? No? Then I would like to thank all of you for being with us, especially Tim, who in the afternoon, and Ken, who's had to go for another engagement. He had to leave. And Balwinder and Pradeep, Siddharth and Sandeep. Thank you so much for making this a great interactive session. And I've learned a lot, and I've made some good friends, and I hope the audience has also learned a lot. Good day, folks. Good night, wherever you are.
Good night, everybody.
And have a great weekend.